It's 9 a.m. How is everybody? Does anybody have any questions for me before we get started? Any questions? I'm going to sit today, guys. I'm sorry, my knee is killing me. Do you guys? Oh, let me turn my phone off. Hold on. Did everybody get my follow-up email?
Yes.
Okay. Were those links helpful for you? You will be getting an email from me after every single class that's structured somewhat like that. It's going to have the link for the replay for that specific class, as well as additional videos that I talked about but didn't actually show for you to be able to review on your own. If you have questions in your reading, make sure you write them down for me, bring them back into class, and I'll be happy to answer them. Okay? All right, so we had the test on page 181 in your spiral book. Did everybody take that test?
Yes.
Did everybody grade that test? Okay, so I'm going to go down the roster here. I'm going to call everybody's name. If you have the score, because each one is worth 5 points. So if you know your score, give me your score. Otherwise, tell me how many you missed, and I'll do the conversion for you. If you didn't get to it, no worries. I'm not that kind of a teacher. Just say pass, and I'll come back to you next class. And I'll just keep asking you until the blocks are filled in. Okay? I know you guys have lives outside of here. All right, Alexa.
I missed 2.
Stop. That was a really big mistake. I didn't realize when I got this that it was voice control, because I got it on one of those like Black Friday deals. And now a lot of times when I'm talking, it will do stuff. And I just wanted a monitor. All right, Alexa missed 2. Tanya. Kira.
195.
Thank you. Carolise. Thank you. Naraya.
95.
Thank you. Christopher.
100.
Thank you. Jada.
100.
Thank you. Peyton.
100.
Thank you. Alex.
100.
Thank you. Jessica. Rebecca.
100.
Thank you. Amy.
100.
Thank you. Fernanda.
100.
Thank you.
I
Stephanie.
missed 1.
Very good. Shayla. Thank you. David.
75. 85.
85. Okay. Ariana. Thank you. And Owen.
95.
Thank you. All right, those of you that missed a question or two, do you have any questions about the ones you missed? So do you know why the right answer was the right answer? Were you able to go back and review?
Yes.
Okay. All right, if you have any questions, please make sure that you ask. We want to make sure that you have a good understanding of all of this moving forward. I do not give tests in class. So I'm not going to test you on this information. It's adult education. Remember, this is test prep. I'm getting you ready for the state exam. So you're going to have to learn how to identify your own, good morning. You're going to have to identify your own knowledge gaps, okay, where you're struggling. And then let me know, and I'll be happy to help you out. All right. Okay, so let's review what we learned on Monday. Man, we went over a lot of information on Monday. A lot. So does anybody have any questions about what we went over on Monday? Everybody good? Okay. So how do we know what to do with each patient?
Care plan.
We follow the care plan. But it's not just the care plan. It's the care plan, the whole care plan, and now that's way more important. I know you guys are, by the end of the class, you're going to be doing this in your sleep, okay? But this statement is probably more important than following the care plan. So the care plan, the whole care plan, and nothing but the care plan, because this is where CNAs go way off track and tend to get themselves into trouble. Okay, we follow the care plan, but CNAs, if they see any gaps in there, they will try to fill those gaps in instead of going to the nurse. So remember, you cannot make decisions. No matter how minor they seem to you, you cannot make decisions. Does that make sense? Good. All right. While we're doing that, while we're following the care plan and doing the tasks that are assigned to us, what is our most important job? Yeah, to make observations, to pay attention to the patient. So remember that the focus isn't on the task. The focus is always on the patient we're doing the task on. If you can make that change in your mind before you get to the test, if you can start focusing on the patient rather than the steps or the skill or your performance, you will do very well in the state exam. Okay, so that's a really big key, is to get your brain flipped over to focus on the patient. So this is something that is a frequent point of failure on the test. One of the skills we're going to learn to do is turn a patient onto their side and prop them there with pillows. We actually get into that next week. I don't think that's on today. No, it's not on today. So when we do that, when we turn a patient over, you're going to be focused on the right technique. How do you position the patient? How do you turn them effectively? You're focusing on the steps. What the evaluator is looking at is, where is the patient in the bed after the turn? And if they're not in the middle of the bed, it doesn't matter how good your steps were if they're too close to the edge of the bed. So that's one of those skills where we really have to think about the patient, not our steps, not the skill. You've got to be able to take a step back and look at the overall patient. Do they look comfortable? Are they in a safe position? So we're gearing up for that, but I just want you to remember as we go through these skills, because we're going to start skills today, as we go through these skills, that it really is all about the patient. And the only way to tell that is through observations. Now, when we make observations, who do we report them to? The nurse. I'm going to give you a hint for the state exam. If there are any answers that say call the doctor, those are not the right answers. Who do CNAs report to? Right. We don't report to the doctor. The nurses do that. Good? Does that make sense? So if you see, and there will be some test questions where an answer is call the doctor, that's not a CNA modality. So keep that in mind. Never the right answer. All right. So when we start every skill, we do the opening. The opening is a very specific set of steps. They all must be completed. I think we're all here. They must all be completed. So every skill starts with the opening, but what does every opening start with? A knock. That's right. And that knock is there specifically to keep the patient in a safe environment, something that they have some control over. Okay, good. So after we've knocked, what's our next step? Okay, so we've got to greet the resident. Good morning. Hello. How are you? Something nice, because remember, it's all about the patient, right? So we want to be nice. So we're going to greet the resident because it's always about the patient. And then we're going to identify them how? By name. Remember, for the test, they actually have to hear you say Mr. or Mrs. Jones. If they don't hear that, you don't get credit for this. And when you don't get credit for this line, because there's 3 things on this line, you don't get credit for any of them. Okay? that make sense? So when they're checking you off on their checkoff sheet, all of those steps, the checkpoints, if there is more than one thing in that sentence and you don't do them all, you don't get credit for any. So when the test is graded, there's never partial credit given. Does that make sense? Never partial credit. So it's all or nothing. So keep that in mind. So once we've identified our patient by name, what do they need to know about us?
What we're there for.
Yeah, who we are. And it's not just our name. If I walk in and say, hey, I'm Patty. So, are you Patty the person that brings the cookies? I like that, Patty. Are you Patty the person that brings the needle? I don't like that one so much, right? So you have to tell them your role. Just because you show up dressed in scrubs does not necessarily mean that you're relevant to them. Everybody in that facility is dressed in scrubs. From transporters to housekeeping to nutritionists to dietary aides. I mean, everybody is wearing scrubs. They have no idea what role you are going to play. And if you think about all the people that work in a medical facility, who are some people that the patient might experience in any medical facility? Who might a patient interact with?
The nurses and doctors.
Okay, so nurses, we have at least 2 shifts, 12-hour shifts, so that's at least 2 nurses. And those nurses probably are going to have a break at some point. So one of the other nurses will cover, right? So you've got at least 4 nurses a day. Who else? Transporters, sure. So if that patient has to go anywhere, nursing staff doesn't do that anymore. We used to. Now we have a whole department that is geared to getting patients from point A to point B and back again. So transporters, and they wear scrubs too. By the way, if you're trying to get into a hospital, a transporter position might be a great way to get your foot in the door while you're waiting on your certification, because you don't have to have any certification, be a transporter. What else? Who else might a patient encounter? Okay, housekeeping. Somebody said housekeeping. Absolutely. Again, 12-hour shifts. Housekeeping is in the room. They have to service every room, every shift. So you're talking about a minimum of 2 housekeepers. Who else?
Specialists.
Okay, so doctors. Sure. Doctors, healthcare providers, nurse practitioners, physician's assistants, the treatment team. Who else? Respiratory therapy. Absolutely. If they're getting any sort of breathing treatment, or if they're on a vent, or there's a lot of reasons that respiratory might be involved, including assessing patients for risks of pneumonia as well. So respiratory will probably be involved. Who else? Oh man, the vampires. Yeah, they come in the middle of the night, usually around 3 a.m., and wake those patients up and stick needles into them. Yeah, who else? Radiology. So radiology can be a lot of different people. You've got x-ray techs. That's what they do, is run the x-ray machines. They don't do anything else. You've got registration clerks in x-ray that are making sure we've got the right patient. You've got CT scan people. You've got MRI people. And then you've got the radiologist that reads all of that. You've also got ultrasound techs as well. So a lot of people in radiology. Who else?
Maintenance.
Okay, maintenance. Sure. If the AC isn't working, if something is broken, maintenance can come in and out. Any others? Okay, so some facilities use medication aids to help the nurses with routine med passes.
Social worker.
Okay, absolutely. Social workers are going to come in to make sure that you have the resources you need in the next step of your journey. It might mean going home with home health. It might be securing a spot for you in a short-term rehab. It could be making arrangements for long-term care. It could be assessing your financial ability to pay for the next steps. So social workers are usually involved along with discharge planners. Now, those are actually two different roles. People get them confused, but there's two different roles there. And discharge planners are always involved. Discharge starts at admission. You have to think about the next step. There's even more. There's dietitians, there's volunteers, there's registration clerks, there's billing clerks, there's chaplains or some other clergy that might come in. There's a lot of people, guys, a lot of people. Just because you walk in and say, "Hey, I'm Patty," that doesn't mean anything to that patient. Nothing. So we've got to make sure that when we're introducing ourselves, we let them know not just who we are, but what we are, to make sure that they're able to form a reasonable expectation of what we can do for them. They're not going to ask a CNA complex medical questions. What does this diagnosis mean for me? What's the next step? Because they know that that's not your role. But incidentally, if they did ask you, "Hey, doc says I've got cancer and they want to start me on this new medication. What do you think? Should I let them do that?" Do you have an opinion on that subject?
No.
No. You absolutely do. Even if you think you have an opinion, no, you do not have an opinion on anything. What you do have is a nurse you can refer that patient to. "I'm sorry, I don't have any information on that. Let me go get the nurse for you. They're better equipped to answer those questions." Good. What I don't want you to say is, "Oh yeah, my mom had that same cancer and they put her on that medication and I don't think it did anything. I mean, she was dead in like 2 weeks."
That'd be horrible.
Right? We don't have an opinion. Even if we think we do not have an opinion on anything. Okay? Good? Makes sense? So when we're doing the opening, it's really important that we understand not just who we are, but what we are. Good? Good. All right. So once we've got all the introductions out of the way.
I have a question.
Yes.
So, you're a CNA and you're in the hospital and patients tend to refer to you as the nurse. They'll say, family members come in and they'll say, "Oh, this is my nurse," but you're not the nurse.
Right.
But a lot of times when I'm in the hospital and I see that, they don't correct that. They don't say, "I'm not the nurse, I'm the CNA."
You should correct it. You should correct it. The patients probably don't know the difference between a CNA and a nurse. They see, you guys are doing a lot of the same thing. Nurses can give bed baths. Nurses can take pulses. Nurses can do all the things that we do. Remember, as the RN, that's my responsibility, is the total care of this patient, head to toe. I can do all of those jobs, but I've also got other nursing jobs that I have to do. And if I'm spending all my time feeding and bathing and grooming a patient, I'm not going to have time to do my nursing tasks. So what I need is a helper. I like that term, helper. I don't like the term certified nursing assistant, because when you put a certified in front of something, it starts you guys thinking that maybe you can do more than you're supposed to do. Helper keeps you very firmly in your lane. So I don't particularly like the term CNA, because I think it empowers you to make decisions you shouldn't be making. So if you just remember you're the helper, and that's how it should be phrased to the patients. "Oh no, I'm not the nurse, I'm just the helper." Or if you don't want to use just, because I'm not trying to minimize your role here, you can say, "I'm the very important helper," because you are. Either way is fine, but you shouldn't let that go unrecognized, because let's play that out a little bit. So a patient has a family member and says, "Oh, this is my nurse." What's your name? Alexa. "This is my nurse, Alexa." No. Okay, we can't use your name. Then the later on, if you don't correct that, if you say, yeah, yes, I'm here, how can I help, whatever. Later on, when that patient has a question, they're going to ask you. So you want to set those firm boundaries pretty quickly because it helps reduce the amount of interruptions you're going to have in your day. You really want to protect your time. And let me explain why. Time management is such an important concept for clinical workers, specifically CNAs. You're the ones at the bedside. Nurses spend about 7 minutes per patient per shift. If you take all the time the nurse spends in the room, 7 minutes per patient per shift. The healthcare team, the doctors, nurse practitioners, physician assistants, they spend less than 1 minute per patient per shift. So that patient requires a whole lot more care than 8 minutes per 12-hour shift. So who is the person providing all the other care? You are. So you are the ones that are in the room the most. You're going to be answering the call lights. You're going to be taking the patient to the bathroom. You're going to be giving them the blankets when they're cold. You're going to be taking care of everything for the patient. You are their point of contact, right? So if you got 12 patients, let's just say you have 12 patients and we're working a 12-hour shift. If you just spend an extra 3 minutes over a 12-hour shift, 10 seconds here, 15 seconds there, 30 seconds there, adds up to 3 minutes over that whole shift. If you multiply 12 patients, extra 3 minutes each, that's 36 minutes. At the end of the shift, you're going to be like, oh my gosh, I didn't get a break today. Do you know why you didn't get a break today? Because you spent an extra 3 minutes with each one of those patients. So we've got to get really good at time management because you want to protect your break. Does that make sense? You're going to need a break, guys. Trust me. You need a break. Dealing with people is exhausting. You need that break. So I want you to be aware of how much time you're spending with each patient and take the opportunities you can to reduce their expectations of you. Otherwise, you're going to be answering a whole bunch of questions, running back and forth to the nurse. So establish expectations early, and that's why I would address that. Good? Questions? All right. So now that we've got all that out of the way, we knocked, we greeted our resident, we addressed them by name, we introduced ourselves by name and title. Now what do they need to know?
What would they do?
Yeah, what are we there to do? You can insert name of skill here. Put it in your own words or read it off the care plan. Nobody cares. Nobody cares. But what do we need to get from them? Permission. No means no. Doesn't matter where they are. No means no. Be very careful with that. This is actually becoming a very hot button issue. And it's because we've had some high profile cases of abuse lately that people are, for whatever reason, streaming onto social media, which just burns my cookies. Bad enough that you are abusing an elderly person who is dependent on you, but you want views for it? I mean, that's just sick. That's horrible. So because we've had some very high profile cases lately, and because of that, this is becoming a real issue. Okay? Does that make sense? You have to make sure that you're getting consent. Have to make sure. Once you get consent, then we can close that curtain. Is that curtain clean? So what do you want to do after you close the curtain? Wash your hands. Very good. Get rid of those cooties. And then once we have clean hands, then we can go get our clean supplies. Okay? Remember, you can't get your supplies until you have clean hands. Good? Okay. So our most important principle here is do not touch the patient until your hands are clean. Very important principle. That will fail you on the test. The end of every skill is going to be done the same way, called the closing. Just like the opening, very prescribed steps. We have to do them to get credit for it. The end of every skill is going to follow the same pattern, specified steps. But the opening, the order mattered. Closing, the order doesn't matter until we get to the last two.
So before you gather your supplies, how long do you wash your hands? Is it the same 20 seconds?
Same 20 seconds. Remember, that doesn't include our nails. So we go to the sink, we turn the water on, wet our hands, get some soap, bring our hands together and start rubbing. And that's when our 20 seconds starts. We have to rub the tops of the wrists, the backs of the hands, and in between the fingers, in between the thumb and index finger, the palm of our hands, in between, interlacing, the bottom of our hands by our pinky. All of that has to take at least 20 seconds. More is fine, less is not. At least 20 seconds. Once you've done that, then you're going to move on to your nails. Remember that 20 seconds does not include your nails. So you'll go down each one of your nails with your thumb to clean your cuticles. You'll circle the nails on the palm of your hand to get underneath and then rinse. Okay, good. Now, for the test, you are going to physically go to the sink and really wash your hands with soap and water for real for your first skill. At the beginning of the first skill and the end of the first skill, you are really going to be washing your hands at the sink for real. After that first skill is done, at some point, the evaluators are going to tell you you can simulate hand washing from this point. Now, simulate means say. So you would say, I would wash my hands here. Okay. So simulate means say. Do you remember where I told you those evaluators want to be?
Home.
Home, in their pools, drinking their margaritas. Used to be Mai Tais, but nobody knows what a Mai Tai is, so I changed it to margaritas. Everybody knows what a margarita is. Okay, so they want to be home in their pools. They don't want to be watching you wash your hands. So let me explain why this might be important. So I'm going to pick on you guys. So you're candidate one. You got 3 skills to do. You've got to wash your hands at the beginning of the first skill, the end of the first skill, the beginning of the second skill, end of the second skill, beginning of the third skill, end of the third skill. How many times does she wash her hands?
Twice.
Well, 6 times
Well,
if we're not simulating. 6 times. Okay. So candidate 2, how many times is she going to have to physically wash her hands at the sink? 6 times. 6 times, 6 times, 6 times, 6 times, 6 times, and 6 times. That evaluator would have to stand there and watch 48 hand washings. Talk about a boring job. Okay, so they're going to watch you wash your hands twice. Once at the beginning of skill 1, once at the end of skill 1. And then they're going to tell you you can simulate from this point. So you would just say, that cuts down on time. Gets them one step closer to their pool. Okay. Good? All right. So the closing, there's 8 C's in the closing. Everything starts with C for the closing. But with the closing, the order of the first 6 doesn't really matter. We don't care how we're going to do this. But what kind of environment should our patient be left in? A clean and safe environment. Clean and safe. So in order to make sure the environment is clean and safe, we want to look around. Make sure the sheets are adjusted appropriately. Make sure there's no trash on the floor. Make sure your table is empty. Look around. Make sure everything is good. Let me talk to you about these tables real quick. We're going to get to this. This is one of the things we're going to learn today, but let's talk about these tables. Anybody ever been a patient at a hospital? What did you use this table for?
Food.
Eating. Yeah, absolutely. So keep that in mind. This is for eating, but what else did you use it for? Everything. Yeah, this is the only surface you have available to you. So it's always got a cup of water. It's probably got a box of Kleenexes, maybe some chapstick, crossword puzzle books, phone chargers, everything. Sometimes flowers. I mean, this for the test, your table is empty. Cool. That makes life easier. In a clinical setting, your table will never be empty, ever. Work around it, carve a space out, empty the table if you can to give yourself a working space. But just understand the test is best case scenario. They make it easy. The bar for the test is really, 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 really low. They just want to make sure that you aren't going to go out there and kill patients while you're really learning to be a CNA. Okay? So remember, the table is not always going to be clean in a clinical setting, but at the end of our skill, we want to make sure that it is. So look around, make sure there's nothing on the table. Make sure that everything you used was put away. So if you used a basin, make sure it's been cleaned and put away. If you use linens, make sure they go in dirty linen. If you took a gown off the patient, don't leave it wadded up at the end of the bed. Put it into the hamper. Look around your environment, clean and safe. The bed must be in the lowest position. That's part of that safety. So the bed must be in the lowest position. We'll talk about that a little later. There's a specific question we need to ask our patients before we leave. What is that question?
Are you comfortable?
Are you comfortable? Now, let me talk to you about this real quick. We talked a little about time management, right? Okay, this is one of the traps that CNAs fall into because you're in the room, you're trying to get out quickly, okay? All CNAs try to exit the room quickly, and I get it. I understand why. But here's where we run into problems. This patient has nothing to do. Nothing to do. And all day to do it. They're a captive audience. And they're bored. But they also get hyper fixated. Now you're going to find this with older people as well. So this is a very good thing to understand. Okay, when somebody has nothing else to focus on, they were hyper fixate on whatever is bothering them at that moment. So let's talk about this lady for a second. Okay, she sees you running around. She knows you're terribly busy. You're short-staffed, and she feels really bad about it. She doesn't want to be a burden. She's a really nice lady. She tries really hard. And at the end of the skill, you didn't ask her, is there anything else I can get for you? And she doesn't want to speak up because she's a nice lady and she doesn't really want to take up any more of your time. So she doesn't say anything. But she's really thirsty. And you walked out of the room and you go down and work on somebody else and she's laying there really thirsty. And she has nothing to distract herself from the fact that she is really thirsty. And she will try her best not to bother you, but at some point, because she has nothing else to think about, she's going to hit that call light because she is really thirsty. So you stop what you're doing and you go in the room to find out what's wrong, because every call light should be treated like an emergency, even though 99.9% of them aren't. We still treat every call light like an emergency. So you walk in the room and she says, I'm so sorry to bother you, dear. I really am, but I'm really thirsty. Can you get me some water? Sure, no problem. Let me get you some water. So you go get her a pitcher of ice water. You bring it to her. And you don't ask, is there anything else? Because you're trying to get back to your other patients and you just want to exit the room. So you run out of the room. And she's laying there and that ice water made her so cold. And the facilities are cold already. And all she's wearing is a thin gown and she's got a sheet, but nothing else. So she starts shivering. And her sweater is in the closet across the room and she can't get there. So she's just sitting there shivering, and she has nothing else to think about. So after about 20 minutes of shivering, what is she going to do? Hit the call light. Yeah. And, oh, dear, I'm so sorry to bother you, but can you get me my sweater out of the closet or a blanket? I'm freezing. Sure, let me take care of that. And then you walk out of the room. Well, she had water. And now she's nice and warm.
Yeah.
So what do you think she's going to have to do?
Go use the bathroom.
She got pee. she's got to pee. So now she's thinking about how much she's got to pee. And she has nothing else to distract herself. So after about 20 minutes, what is she going to do? Hit that call light. Oh, dearie, I'm so sorry to bother you, but I really have to pee. And I need some help. By now, you are so frustrated with this woman. You're threatening to hide her call light. You are just ticked off because she is interrupting your workflow, not realizing she's the whole reason you have a workflow. And you start copying an attitude with her. And then you label her a difficult patient. Is she a difficult patient? No. If you had just said at the very beginning, thank you so much. Is there anything else I can get for you while I'm here? Maybe some water or a blanket? Do you need to use the restroom before I leave? If you take care of everything that needs to be taken care of while you're there and don't make her feel rushed, you just cut out 3 or 4 call lights later on down the road. Do you guys see how that works? So when you're doing your closing, it's not required. It's not on our banner. It's not a checkpoint step. But if you work it into your workflow to start asking your patients, is there anything else I can get for you while I'm here? You will save yourself a ton of time in your career. Does that make sense? It also leaves your patient feeling cared about as well as cared for. Okay. Now, there are some patients, I am not going to lie to you, there are some patients that I had to bite my tongue and grit my teeth to be able to get that out, because I knew that if I asked them, is there anything else I can get for you, I'm going to be there a while, because they will come up with something, right? But it's still better than having them on their call lights interrupting you when you're trying to work on another patient. Does that make sense? Okay. So ask about comfort. Part of this is also going to be emotional comfort. So we're going to offer a magazine. I know we're not passing magazines around, but we're going to do this as a placeholder just to make sure that the patient has something emotionally to do. You know, this topic is near and dear to my heart because my mom took care of my grandma in the last years of her life. And my grandma had nothing to do, and she would sit in her recliner. And my grandmother was you're going to hear all about my grandma through this course, but she was a very prim and proper woman. She was the kind of woman that when you got out of bed, you made the bed. As soon as you get out of it, the bed is made. Hospital corners. I learned how to do hospital corners when I was 2. Hospital corners. So at the end of her life, when she had nothing else to do, her eyes were bad, she couldn't read. She was tired of all the stuff on the TV because they lived in very rural areas, so they didn't have cable. So it was rabbit ears only. Very little on TV. So she got nothing to do. And the CNA that would come in and help her with, showering and dressing and make her bed never made the bed quite right. And she would sit there after the CNA left and she would stare at that bed because she had nothing else to do. And after a little while, she would call my mom and ask my mom to come in and remake the bed. And my mom would just get lit. Who cares? Who cares? The bed is made. It doesn't need to be made to your spec. But it would drive my mom nuts because she had things to do. And Graham did not. So this set up a lot of conflict, right? So we kind of have to understand that just because we're busy doesn't mean our patients are. So a lot of times giving them something to do can save you a ton of time. They need distraction. So word searches, crossword puzzle books, Sudoku, find something for them. But for the test, we're going to offer them a magazine. All right. Patients have to be covered when you leave them. Sheets, clothing, blankets, don't care, but no knobby knees should be showing unless the patient is requesting it. For the test, the patient will never request it. So for the test, should I ever be able to see those knobby knees? Make sure the patient is covered. Okay. We're going to open that privacy curtain. We're going to give them the call light. I always tell them how to use it too. Press that button if you need me. Remember, they're medicated. They're self-absorbed. They may not be familiar with how to call us. And then we're going to wash our hands. Now, those steps up until hand washing, doesn't matter how you do them. But it should sound something like this. Thank you very much, Miss Jones. Is there anything else I can get for you while I'm here? Are you comfortable? Would you like a magazine before I go? That is in the low position. Environment is clean. Here's your call light. You can use the red button if you need me. I'm going to open the curtain and go wash my hands. So it should sound something like that. Now you can put that in, I'm sorry, would you like, I don't think, did I say magazine?
Yeah.
Okay. You can put it in any order you want to put it in, but create an order and stick to it. Okay. So a good way to kind of remember this is comfort, curtain, call light, clean.
Magazine.
Yeah. And that's, magazine's part of comfort. So yeah, magazine is good. Oh, good morning, Lynn. Lynn starts clinicals in about an hour and a half. Oh, the exam. Oh, good luck to you. Lots of good vibes out to you. You're going to do great. Let us know how you do. All right. So once we've washed our hands, then if we need to chart, that's when we'll do it. Remember, you don't want to pick up your pen with dirty hands. So all of those steps, wash your hands, document, and then we have to end skill with clean hands. So after we document, we will wash our hands again. Remember, washing your hands is the very last action for every skill. Good? Questions? Let's talk about hand sanitizer. This is Jeremy. Ain't he cute? This is my hand sanitizer. How many of you guys are familiar with hand sanitizer? Okay. The problem with hand sanitizer is that we have some false expectations of it. So I've got to ruin those for you right now. When it comes to hand sanitizer, and you're going to see it used in all clinical settings, it actually does something a little bit different than hand washing. So hand washing is designed to flush those pathogens down the drain, to actually remove the pathogens from your hands and get rid of them. Okay, and that's why we've got to get all of those little nooks and crannies, all of those areas. Hand sanitizer does not do that. Hand sanitizer breaks down the envelope that holds the pathogen together. Think of it like a membrane, okay? So it breaks down the membrane of the pathogen. So it kills the pathogen. And it kills about 99% of the pathogens. But if I use hand sanitizer and I've killed all those pathogens, where did they go? Yeah, they didn't pop into the atmosphere. They are still on my hands. So if I'm going to eat and I use some hand sanitizer before I eat, I'm eating my French fries with a side of dead E. coli, which isn't much better than live E. coli. Does that make sense? So if you're going to bring your hands anywhere near your face, you need to go wash the pathogens away. Don't just use hand sanitizer to kill them because you're still going to be depositing them. So remember that if we're going to eat or drink or use the restroom or smoke or talk on the phone, you don't want to rely on hand sanitizer for that. You physically want to wash your hands. But the real problem with hand sanitizer is that we don't use it correctly. Yes, it kills pathogens, yes, but only if we use it correctly. Now, when we use hand sanitizer, normally we do something like this. Right? Does that look familiar? Yeah, that was not nearly long enough to kill to actually penetrate the membranes of the pathogens. In order to do that, I've got to use enough to have my hands visibly wet, and they have to remain wet as I rub them together for at least 20 seconds. So I want you to think about how long you normally rub your hands together with hand sanitizer. And it's probably not 20 seconds. So when we use hand sanitizer, we generally don't use enough. We don't rub all areas, and we don't have it wet for the right amount of time. So when you're using hand sanitizer, make sure that you adhere to the rules. So 20 seconds. So for me personally, if I've got to have my hands wet for 20 seconds anyway, and I know this is going to leave dead pathogens on my hands, I'd rather just walk over to the sink and wash them away than use hand sanitizer. You will have hand sanitizer in clinical settings. You can use it. It's perfectly okay. But we have to remember that it does have limitations. And one of the big limitations of hand sanitizer, though, is that there's two pathogens it does not work on. Those two pathogens are norovirus, which is a 2 to 3 day stomach virus, causes vomiting and diarrhea. It's really nasty. Makes you feel like crap for like 2 or 3 days. It's horrible. We call it the daycare disease or the cruise ship disease because it spreads very rapidly in confined areas. Hand sanitizer does not work on it. Does not work on it. The other thing that hand sanitizer does not work on is C. diff. Now, if you think norovirus is bad, C. diff causes the same symptoms for 6 to 8 weeks. And it's horrible. And C. diff kills people because it absolutely depletes their system. So if we know that C. diff and norovirus are not killed by hand sanitizer, we should not be using them if we're caring for patients with those two conditions. That could be a written test question.
Why did the hospitals allow them?
Because that's only 2 out of a bazillion pathogens. So they're kind of a broad stroke.
They're willing to take the chance.
They are. Now, I'll tell you why they can't get healthcare workers to go to the sink and wash their hands.
Okay.
Sad.
It is sad. It is sad. Now, when my mom was in the hospital, she had an intestinal abscess. She had a drain put in. It was a very bad thing, and her immune system was like wiped. Everybody that came in that room, I made absolutely sure that they went to the sink and washed their hands. And I actually had a couple push back and say, well, I use hand sanitizer. And I would say, no, I know there's norovirus on this hall. So please wash your hands. I'm not taking any chances with my mom's life. So if I'm not taking chances with my mom's life, do you think that all of our patients might have a similar, mindset? So if your patients ask you, could you please wash your hands? Don't give them attitude. Go wash your hands. They're doing what they need to do to protect their family. And I can respect that.
I missed what you said. Any question? I was writing notes. I'm sorry.
So a possible test question would be, it could be a concrete question, which means which of the following pathogens is not killed by hand sanitizer? Norovirus or C. diff would be one of them. But you might also have something like you are caring for a patient with C. diff. Which of the following principles would be important to remember for this patient? A, hand sanitizer is not effective at eradicating C. diff. B, the patient needs plastic utensils C, the patient's going to be cold all the time, will require extra blankets. Or D, this patient will need assistance to the bathroom. Well, given the information I gave you, the only possible answer is A.
So will the questions on the exam be like 2 answers can be correct, but 1 is more correct?
Yes, and the ebook that I have will go over that in detail for you. Yes, you can usually get rid of 2 answers right off the bat, and then you're left with 2 that are like, it could be, maybe, I don't know. And that's where we go back to know your role, know your normals, patient rights, safety, and infection control. Because the answer that's what they're testing you on. So whichever answer fits into that category.
So like if there's a question and it's like the same, but like you go on down the road and it's the same question, but worded different, is that going to be?
Could be, yeah. So most of the test questions are scenario based. They're going to say, what are you going to do when? So the majority of the questions, there are a few what we call concrete questions. A concrete question would be, what color is the sky? Right? So it's a very concrete question. Red, blue, yellow, or green? Blue. That's a concrete question. It's just asking you to regurgitate information. CNAs don't regurgitate information. That's not what we do. CNAs act. They do things. So most of the questions on the state exam are going to be geared toward action or scenarios. What are you going to do when you see this or get this or hear this or do this? So most of the questions are scenario based. Now, you guys, I haven't talked to you about this. I'll actually talk to you about it a little later in the program, but I do a live game show on the 1st and 3rd Tuesday of every month. So the last week of your the 3rd week of your program, I will have a game show on Tuesday. And it's free. It's on YouTube. You just go to YouTube, my YouTube channel for your CNA, at 11 a.m. on Tuesday, and I go through 15 potential test questions, and it's a true game show. You put your answers in the chat. My program reads those answers, awards points. I give out prizes, real prizes. People compete from all over the world, and it's a lot of fun, but we go through 15 questions, so it gives you an opportunity to kind of see the types of questions you'll have on the state exam, interact with them. And then when I reveal the answer, I also explain the why behind the answer. So it's a great way to prepare for the test with practice questions. It's a little more engaging than just a practice test book. All right, so everybody got what they need for hand sanitizer? It's a good alternative, primarily because we can't get you to wash your hands. But if you're going to be working with C. diff patients, norovirus patients, or if you're going to have your hands anywhere around here, you need to make sure that you've washed them. So we've gone over these 3 principles, okay? We've learned skill rules, we've learned the opening, and we've learned the closing. We just reviewed all of them. And we're going to start on skills now. So we're going to put these 3 principles to work for us as we're learning the skills. But if you remember something I said on Monday, I said that there's the big 4. 4 principles that apply to every single skill. I don't have my, sorry guys, I don't have my mic on. 4 principles that apply to every single skill, no matter what it is. The big 4. Well, we're getting ready to start learning skills. That means that we have to learn the last principle in the big 4 in order to learn how to do skills. Sorry, guys. Hopefully that's better for you. All right. So remember, skill rules tells us what to do, care plan. The opening is how we begin every skill. Knock, knock, knock. Hi, Miss Jones. My name is Patty. I'm your CNA today. I'm here to whatever. Is that okay? Close curtain, wash hands, get supplies. And every skill ends the same way. Thank you very much, Miss Jones. Is there anything else I can get for you while I'm here? Are you comfortable? Would you like a magazine before I leave? Your environment is clean, bed is low. Here's your call light. If you need anything, hit the red button. And let me open your curtain. Then I'll go wash my hands, document if I need to, and wash my hands again. That's the closing. There's a lot of steps to the closing. A lot of steps. Once we do the closing, I probably would go back and read that care plan one more time just to make sure I did everything right, and then tell the evaluator my skill is done. Remember, you can make corrections on anything until you say my skill is done. Once you've declared that you're finished, I don't care what you remember, they're not going to let you correct it. Okay, good. All right, so we're going to learn our very first skill, which is measure and record the radial pulse. This is on page 52. So this is a skill summary sheet. It basically, at first glance, it looks very simple, but it basically tells you everything you need to know about the skill. So going down the side, you'll see the principles that are involved. They're spelled out for you here. You'll see the specific steps for pulse in the black banner. Up at the top is a Cliff Notes version or short version of the skill, important points, assuming you know a few things. There's a video for it. And the bottom tells you some test-specific information. So somebody with your level of experience, which is none, should be able to complete this skill in 5 minutes or less. Okay, 5 minutes or less. That's what they say you should be able to complete this skill in. You're going to be doing it on a live person, another testing student. That means somebody might be taking your pulse for the test. Or if you're going to take a pulse, you'll be doing it on a live person, not a mannequin. That person will be positioned in bed, not sitting in a chair, not at a table. They're going to be already positioned in bed, and you have to document for this skill. Documentation is required for this skill. Good? Questions? You can be off by 4 beats in either direction and still be accurate. So let's say that the evaluator got 76. If you got 72, 73, 74, 75, 76, 77, 78, 79, or 80, you're still considered accurate. Guys, that is a huge margin of error. You could drive a truck through that margin of error. They give you, it's not about showing that you're a perfect CNA. It's not about mastering and demonstrating that you mastered. It's all about showing that you've got a very basic understanding and you're not going to kill the patients. So I need you to adjust your test expectations accordingly, okay? It's not about perfection. I'll go a step further. I'm going to tell you that the number really doesn't even matter. This skill is all about following the care plan. That's what this skill is about. So if the evaluator got 76, but you got 62, you can still pass. You'll get a deficiency for not being accurate, but you'll still pass it as long as you do all the other steps properly. It's not about accuracy. It's about showing that you know how to follow the care plan. So if we're going to be following the care plan, we need to read the care plan and know what it's going to say. We're going to get to that in just a minute, but keep that in mind. Okay, if we're going to follow the care plan, we've got to read the care plan. We're going to get to that in a minute. But if we go back here, you can see that all the principles that are involved, we know skill rules, yay. We know the opening, good. We don't know glove rules. We don't know pulse rules, but we do know the closing. So out of these 5, we know 3. So let's learn the other 2. Okay. So we know skill rules, we know the opening, and we know the closing. Let's get into glove rules. Now, buckle in because this is going to take me some time to go over with you. My life would be way easier. Let me just get this out of the way. I teach the way I do because it's effective. It's effective. Thousands of people before you have proven that it is effective. So I know I say the same things over and over in slightly different ways. I'm doing that because you all have different learning styles. And if you don't get it the first time, if I put it a little bit differently, you'll pick it up. If you did get it the first time, I'm just reinforcing it. It works. Okay. So I need you to have some faith in that. But let me explain something to you that's very interesting. There's a lot of instructors out there that just tell their students, wear gloves for everything. You can't go wrong by wearing gloves for everything. That would make my job a whole lot simpler because I'm about to go into an hour lecture. I could save all of those words just by telling you guys, wear gloves for everything. And a lot of instructors shortcut and do that. But that is absolutely contrary to best nursing practices. You should not be wearing gloves for everything. And I'm going to explain why. Okay. And that's what we're going to get into here. Why can't we wear gloves for everything? So this is going to be in all skills. I do have a video on it. You can watch if you want, but we're going to get into this in person. So this is part of the big four. Let's see here. Anthea. All right. Anthea says, good morning, Miss Patty. I passed my skills, but failed on written. I got 72%, but where I failed was in the role of the nurse aide and patient safety. So, Anthea, I would suggest that you get our ebook. It's, she says, I see you're a good individual and I do like how you teach. Thank you so much. Oh, thank you. Here, this is the ebook. Get the ebook. It's free. It'll help walk you through those specific topics. So, role of the nurse aide. Remember, we follow the care plan. If we can't follow the care plan, who do we tell? The nurse. Absolutely. That is the role of the CNA. All right. So let's get into glove rules. I have notes for you, page 41. Notes. But in order to effectively demonstrate this, we're going to do something that has nothing to do with healthcare because I find that this demonstration is way better at helping you visualize the impact that all of these actions have. Okay. So, do you know when they're opening?
Actually, we're opening Wednesday.
Do you work there?
Yes.
Oh, awesome.
You can get 50% discount. I'll give it to you.
Oh, wow. Cool. Yeah,
we're opening on Wednesday.
I went Monday hoping I could get us up, but yeah, cool. Okay. All right. Good insider info. Okay. So let's build a sandwich. Okay. So we're going to do this together. This is a group activity. You're going to tell me what you want, and I'm going to build the sandwich. Okay. And you probably don't want me touching your sandwich with my bare hands. You don't know where they've been. So you're going to feel much better if I put on those little plastic service gloves, aren't you? Let's take a look at that a little closer. So in order to make a sandwich, first, we're going to put on our gloves, and then we're going to ask you a question. What bread do you want? White. Okay, so I'm going to go over to the bread cart, move the little plastic thing out of the way, and I'm going to grab a loaf of white bread. We're going to put it on the counter, and I'm going to take the knife that's on the counter, the serrated knife, and I'm going to open that bread up and fold it over so I can put some condiments on it. Would you like some mayonnaise? Okay, so after I open it up, I'm going to use that mayonnaise spreader. It's kind of stuck in the mayonnaise. I'm going to pick that up and spread the mayonnaise on the bread. And do we want anything else? Honey mustard or spicy mustard? Or
spicy mustard. So I'm going to get one of those little bottles and I'm going to squirt that on as well and put the bottle back. So now we've got bread, mayonnaise, some other sauces. And once we get that, let's put some bacon on because everything is better with bacon. So we'll grab the thing of bacon. We're going to put that on. And what kind of meat do we want? More bacon? You want ham, turkey, ham? Okay. So once I get the sauces on and the bacon on, I'm going to open that little refrigerator under the counter and I'm going to grab the ham out and close that refrigerator and put the ham on. How about some cheese? Provolone. This sounds like a good sandwich. I'm hungry. So I'm going to go over to the cheese drawer, open the cheese drawer. I'm going to look in there for the provolone and we're out of provolone. So now I got to go to the big cooler, open the big cooler, walk in, and they've got, the little bins. So I'm going to open the bin, find the provolone, and then we're going to take it out to the slicer. So we're going to slice that provolone, and then I'm going to put the slices we're not using back in the cheese drawer. So do we want this toasted? I'm sorry, did I skip you? I skipped you. Do we want this toasted? Oh, okay. Yes? Okay. So let's toast that. So we got to wait for the toaster. So we're just going to kind of hang out waiting because somebody else is using the toaster. And then it's our turn to use the toaster. And we've got to touch that little dial to turn the time, right? And open the toaster oven door. So we put our sandwich in. It finally dings. We grab that paddle and pull it out and put the sandwich back on the counter. So now how about some toppings? Lettuce. So I'm going to reach in that little bin of lettuce, get some lettuce and spread it. How about some tomato? So I'm going to get a couple tomatoes out and spread them. Pickles? No pickles. Yeah, pickles. You want anything else? Black olives, onions, green peppers, banana peppers. Okay, so I'll reach in and get that banana pepper. We're going to squeeze those out because they're a little drippy, right? And put those on. How about some salt and vinegar? Oh, salt and pepper, vinegar and oil. Okay, so I'm going to sprinkle the salt and pepper and the vinegar and oil. And then I'm going to take that knife that we used earlier to slice the bread. I'm going to shove it in the sandwich and fold it over and cut that sandwich in half. And then we'll wrap each half up. And then I'm going to go over to wherever we type our stuff in, and I'm going to type it in and get the little sticker, put the sandwich in the bag, fold the bag over, put the sticker on the bag, and I can hand it to you. You want to eat that sandwich? I do. I'm hungry. That sounds like a good sandwich. You guys were happy I was wearing gloves before. You didn't want me touching your sandwich. But did you really stop to think about what those gloves were touching? What's that?
Your hands, your unwashed hands.
Yeah. So we have to be aware that when we wear gloves routinely, we start touching things that we stop paying attention to. Does that make sense? So in this illustration, let's look at all the things those gloves touched in addition to your sandwich. So it touched the bread cart. It touched the knife to cut the bread. It touched the mayonnaise spreader, other sauce bottles, the outside of the bacon package, the cheese drawer, the door handle, containers inside the cooler, the slicing machine, the table while we were waiting for the toaster oven controls, the paddle, the lettuce, tomato, and other toppings, and the wrapper. Did those gloves protect your sandwich? No. You got just as many pathogens on that sandwich as you would have if the person's hands were ungloved. So what did those gloves really do? They gave you a false sense of security. That's the only thing they did. That's it. Now, this was still I still ate this sandwich. I went and took these pictures. Okay. Told you everything in here I do myself. I went and I went, you guys all know where, we're not going to say it because we're on live, but you guys know where I went. Okay. And I ate that sandwich and it was delicious. It was. So I just pointed out everything that was wrong with it. So why did I eat it? I was hungry, sure. But I also know that my immune system needs a little bit of a workout to stay healthy. It's okay. Little bit of a workout. I am not sick. I have a healthy immune system. Perfectly okay. Now, that changes when we start talking about patients. Do they have a healthy working immune system? So we've got to think about this a little bit differently when it comes to patient care. This is perfectly okay for you guys out in the community, but it's not okay for our patients. Now, it's further amplified by the fact that in our clinical setting, these are not garden variety pathogens we're dealing with. These are big, bad pathogens that are bad enough to make someone sick enough to be here. We don't want to be spreading these pathogens all over our population. So we've got to think about gloves a little bit differently. We have to start thinking about who those gloves are really there to protect. Now, as healthcare workers, we tend to think those gloves are there to protect us. That's our mindset. I know there's pathogens. I don't want those pathogens. I'm wearing gloves to protect myself. Remember, you're the one with the good immune system. Who's the one that doesn't have the good immune system? The patient. So those gloves are there to protect the patient as much as they're there to protect you. Do you guys understand that? So if we get into a situation where all we're doing is putting on gloves because it becomes routine and we wear gloves for absolutely everything, every time we walk into a room, we put on a pair of gloves, we stop paying attention to what we touch with those gloves.
That's what happened at COVID, though. I've seen everybody wearing gloves in supermarkets.
Yes.
Everywhere.
Yes.
Yeah,
Yes.
touching cards, touching food, touching vegetables.
Yes. Yeah, gloves are one of those things that people have a how do I put this? Have you ever heard the saying, a little bit of knowledge is dangerous? Right? That's what's happening in that situation. People didn't want to touch anything. COVID doesn't come through your skin. We're going to talk about that in a minute. But pathogens don't come through your skin. So touching the ketchup bottle at Walmart is not going to hurt you. But people were so afraid because it was new. We didn't have any information on it. So people were afraid and they were taking extreme measures, which ultimately put them at more risk because we stopped paying attention to what we were touching with those gloves. Does that kind of make sense? Good. So we've got to be a little smarter than that. So in order to understand what gloves do and why wearing them is important in some situations, but if we're going to wear them, we have to make sure we're following the rules for them. In order to understand that, we've got to go over a concept called the chain of infection. Anthea, just click on the link that I put in the chat for yourcna.com/ebook. Just click on that link and sign up, and it'll be emailed to you. All right, so let's talk about the chain of infection. So this is going to be on page 123 because infection control is as easy as 1, 2, 3. So what you see on the page, remember I took all your notes for you. You don't even have to take notes in my class. So when we talk about the chain of infection, this is something that was developed years and years and years and years and years and years and years ago. But it helped explain how pathogens get from one person to another to make them sick. Okay. Every pathogen has a preferred way of traveling. So when we talk about pathogens, the way that measles is transmitted from one person to another is completely different than the way HIV is transmitted one person to another. Every pathogen has their own way of traveling. I need you to understand that. This helps understand at a bigger level, a big bird's eye view. Okay. So first, when we're talking about the chain of infection, the first thing that we need is a pathogen. No pathogen, no problem. If you don't have HIV, you certainly can't give it to him. If you don't have hepatitis C, you certainly can't give it to her. You can't give something you don't have. I don't have $1 million, therefore I will not give any of you $1 million. I don't have something, I can't give it. Okay. But once a pathogen exists, it has to follow some rules. So pathogens have to have a place to live. They don't do well homeless. Pathogens, like me, do not do well. I would not make a good homeless person. I like creature comforts. Out there in that heat, no, I want AC. Okay. I have to be in a comfortable environment. So do pathogens. So pathogens don't live outside in the environment very well. In fact, usually a couple of hours is about all they can manage before they die. So if there's a pathogen on that table from the last class, it's inactive. It's not a threat because they don't live on the surface very long. Good? Makes sense? Okay. Some live a little longer than others. So that pathogen, once it's in existence, has to have a place to live. We call this a reservoir, or when it's a human, a host. But if there's HIV out here on the table, it's kind of a threat to me. As long as I'm not touching it, though. It can't fly, it can't jump, it's just there. Not really much of a threat. And it'll die eventually. Make sense? Okay. So pathogens have to have a place to live. Now, when they're in that place to live, it's comfy and cozy and they don't want to leave. They like it there. In fact, in order to get them out, it usually takes a little bit of force. How many of you guys have ever had a head cold? What does a head cold make you do? What are your symptoms? Okay, so runny nose. What about coughing? Sneezing? That's all force. When you have a runny nose or you're coughing or you're sneezing, it's not the pathogen that's doing that. It's your body trying to get rid of the pathogen by pushing it out through coughing and sneezing and runny nose. Make sense? Got it? Okay. So pathogens, they're not leaving on their own. They're in a nice, comfy, warm environment. They are set. They want to stay there. But the body tends to try to push it out. So when we have a respiratory condition, that's what's going to push it out. Coughing, sneezing, runny nose, and stuffy actually is trying to close up the gates so no more pathogens come in. That's why you get a stuffy nose. Now, with blood-borne pathogens, HIV, hepatitis, that type of thing, Those pathogens, they don't get pushed out through the respiratory tract. That's not how they leave. They have to leave through blood or body fluids. So if you get cut and you bleed, that's how they get out. If you're having unprotected sex, that's how they get out. Urine and feces, that's how they get out. But they don't come out through the respiratory tract. Good? Makes sense? So every pathogen has a way that it will be ejected from the body. But remember, they're not leaving on their own. They have to be forced out. They like it there. They're happy. All right. So remember, no pathogen, no problem. Right? We have to have a pathogen. That pathogen has to have a nice, warm place to live, and it's happy there. It's a home, not a prison. In order to leave, usually it requires a little bit of force. Now, when it's forced out, it's normally going to leave through a normal doorway in your body. They don't punch through the skin. So it's going to leave through your nose or your mouth or your genitals or your rectal area or a wound, rash, sore, incision. It's got to have a doorway out. It can't punch through the skin. So we call these wet body openings. Eyes, nose, mouth, genitals, rectal area, wounds, rashes, sores, and incisions. These are all areas that a pathogen can get out. We're going to get there. So wet body openings are a danger. So if we're going to touch wet body openings, we probably want to have a set of gloves on because we know that's where pathogens exit. Good? Questions? So wet body openings are eyes, nose, mouth, genitals, rectal area, wounds, rashes, sores, and incisions. But pathogens don't have wings and they don't have feet. They can't travel on their own. They are literally just a blob. In order for a pathogen to get from you to me, there has to be a vehicle. They have to hitch a ride. Now, this is where, as healthcare workers, we start to get interesting. Okay? Because if you've got HIV and you're way over there, that HIV, even if you bleed all over that table, is not a danger to me over here. I'm far away. It can't fly. Can't fly. Now, if you have a respiratory condition like measles, and those pathogens are super itty bitty teeny tiny, they're like the smallest pathogens, they can hitch a ride on dust mites in the air. Normal colds, COVID, influenza, that type of thing, those are heavier. Well, they're not hitching a ride on dust mites. They're too heavy. They are going to travel in liquid that comes out when you're talking, eating, laughing. So that's droplets. So some pathogens travel through the air on dust mites, or not mites, sorry, dust particles. Sorry about that. Some pathogens have to travel in liquid through droplets. Those aren't going to spread very far. And some pathogens have to travel in liquid through the blood, urine, feces, or sexual fluids. So what we need to know in order to stop these things is how does this pathogen normally spread? Through air, through droplet, or through contact. These are the different types of precautions you're going to see. Airborne, droplet, and contact. Good? Okay. A good rule of thumb, a good way to remember this is that pathogens, in order to get around, have to either float or flow. They can't get around on their own. So they either have to float or flow. They can't get around on their own. So if I'm going to touch something that's liquid on a surface, would I want to touch that with my bare hands? No, because that's a flow. Okay. This is called the mode of transmission. This is how pathogens get around. Every pathogen's a little different with this. Now, when COVID first came on the scene, we had no idea what its vehicle was, how it got around. Did it get around on air currents? Maybe. Was it a droplet thing like the flu? Maybe. Was it a bloodborne thing? Maybe. We didn't know. We had no idea. So, if we have a pathogen and we don't know how it's getting, we have to study it. We got to figure it out, right? If we don't know, then maybe it might be a good idea for people to put up a barrier just in case. Because if it's airborne, if we make it like get through some hurdles, maybe it'll infect fewer people. So we started wearing masks just to give it an extra barrier, something that had to get through until we could figure out how it was transmitted. Okay. After a couple of weeks, when COVID was around, they started to realize, okay, they did air samples. We did some science, try to figure this out. And they said, okay, it's not really airborne. Now, airborne is super scary. If we have a pathogen that's airborne, there is not much you can do because you can't like scrub the air. Okay. So if there's a brand new pandemic that's airborne, that's when I would get really concerned. If it's droplet, which is what COVID turned out to be, just like the flu and head colds, if it's droplet, that means that every time you talk and eat and breathe, you're pushing out a little bit of those droplets. They're going to land around you. So like within 6 feet. You over there, I can talk over here. You're over there. You're fine because it's not going to travel that far. Does that make sense? So do you guys remember being told to socially distance and stand 6 feet apart? Are all these things starting to come together now? Okay. So droplet means we need a 6-foot perimeter to keep our droplets from getting into anybody else's holes. Good? Okay. All right. So this is called the mode of transmission. But getting out of one host doesn't really affect anything. That pathogen has to be able to get into another host. Now, this is a doorway situation. A doorway situation. Pathogens cannot break through your skin. There's not a single pathogen on this planet that can break through your skin. None. God help us if there ever is one, but none. Your skin is the best set of gloves you will ever use. Pathogens can't get through. So that's important for us to know. So if there's HIV blood on that table and I put my hand on the HIV blood, that HIV is not going to get through my skin. Not ever. But chances are my hand will go up near my face at some point. You just had your hand up there. You just scratched your face. You were leaning on your arm. You are too. So are you. You guys touch your face on average about 30 times an hour and don't even realize it. So that's where gloves come in. You won't put your hands up around your face if you have gloves on them because it's a visual reminder not to touch your face. Does that make sense? That's where gloves come in. Because just like those pathogens needed a doorway out, they also need a doorway in. I kind of look at them like little vampires. You know, have you ever read a vampire story? They can't come in unless they're invited, right? So pathogens are just little vampires. They can't come in unless they're coming in through a door. They don't break down the walls. So if I have HIV blood on my skin, it's a little icky, sure, absolutely, but it's not going to enter me. It has to get into my body. So how does it get into the body? Well, the same way it got out of the other body, through an open door. Things like eyes, nose, mouth, genitals, rectal area, wounds, rashes, sores, or incisions. So just like you were saying, pathogens use a doorway out, but those same portals of exit can become portals of entry. Good? Makes sense? But just getting into me doesn't really matter, right? If HIV is inside you, you spring a leak, it's now on the table, I walk over to the table and get it on my hand, and I wipe my eye, totally gross, but I wipe my eye with it, and now HIV is inside me, it doesn't necessarily mean that I am going to be infected. You have to think about your immune system, right? So my immune system is pretty strong, probably not strong enough for HIV, but pretty strong. I get adequate rest, I get exercise, I eat right, all of those things. But also if I'm vaccinated. Now, currently we don't have a vaccine for HIV, but we do for hepatitis B. So if I'm vaccinated, then that pathogen, even though it's now in me, can't work its magic. I've stopped it. So let me explain to you really briefly what immunity is. Now, this is really important for you to understand because immunity goes both ways. Humans get to develop immunity against pathogens, but pathogens also get to develop immunity against our arsenal of artillery, antibiotics. So let me explain how this works. So let's say that we have a whole group of pathogens waiting out there on the sidewalk, okay? And they want to come in here and infect you guys. So they get together, they strategize, they figure out how to open the door, and they send one in to test the waters, see what's going to happen. So the first bad guy comes storming into the room, and you're the first one they see. So, because you're closest to the door. So he comes in, you look at him, realize he's a bad guy, and you bonk him over the head with, do you have a pen or a book? Yeah, you bonk him over the head with a book. Yeah, it doesn't really do much. Doesn't really, but it scares him off. So he goes back out there and he tells everybody, hey, when you go in, she's going to hit you over the head with a book. So the next one that comes in, they bob and weave because they know what's coming. And they come up to you. Now, you grab a pen and you start stabbing them in the neck. And it doesn't kill them, doesn't do much, but it scares them off. So they go back outside and they said, okay, first one's got a book, second one's got a pen. And they develop this little armor plate. So now the third one that comes in, they dodge and weave. They've got an armor plate against the pen. They come up to you and you've got that cup. So you start banging them on the head with the cup. Doesn't kill them. They run back outside and they say, okay, book, bob and weave, armor plate for the pen, and let's wear a helmet now for the cup. So the fourth one comes in with an armor plate, a helmet, bobs and weaves. You pick up that fire extinguisher and you lights out. You manage to kill him. Okay. So now he can't go out there and tell anybody about that fire extinguisher and how to kill. So they don't know. We keep that secret because we killed the only person that would know, the only pathogen. Does that make sense? Good. Okay. So, how many of you guys have ever been prescribed antibiotics? How many of you took every single antibiotic like you were told to do? Most people don't. They take them until they start to feel better, and then we put them in the cabinet for next time, later. Absolutely. Most of you guys probably have antibiotics at home, long expired, but you're saving them for whatever. What you have done is you have killed some of those pathogens, but the ones that remained now know all of those secret arsenals. And that's how we developed antibiotic resistant bacteria. Because the bacteria that have been exposed to those antibiotics and were able to overcome them because you left survivors, that antibiotic will not work on anymore. So just like pathogens can develop immunity, we can also develop immunity. So if we see COVID, if COVID enters us, our body battles it, and we are victorious, we win, we now know what works. We can bypass the book and the pen and the cup and go straight for what works. Does that make sense? So when your body gets infected with something, your immune system starts throwing all kinds of stuff at it to figure out what works. And when it finds the secret recipe, it writes it down and puts it in a filing cabinet. And the next time you get infected with something, a white blood cell goes to the filing cabinet, looks through and says, hey, is this the guy? Is this what he looks like? I know how to kill him. And then it puts out the instructions and you get better. Does that make sense? Okay. Or the pathogen isn't able to infect you at all because we know how to get rid of it in the beginning. It can't multiply. Make sense? Good. That's what a vaccine does. Instead of your body having to go through book, pen, cup, fire extinguisher, we already know that because we've done it in the lab. We just write down instructions and we put them in your body in the form of a vaccine. Hey, if you see this guy, this is how we kill him. That's all a vaccine is a picture of the pathogen and instructions on how to kill it. Now, you can go the natural route. You can get infected and your body can figure all that out itself. But in the meantime, the pathogen is going to make you sick while it's trying to figure it out.
Why doesn't that work with COVID vaccines? People that have COVID and have gotten the vaccine and still get sick.
Okay, so the reason viruses are a little harder to work with, and the reason is they mutate. And they mutate very rapidly. Okay. So have you guys ever seen like movies where somebody is trying to hide from the law, run away, right? If they did something bad and they're trying to run away, they usually go to a drugstore to get hair dye. Why do they do that? Right. They're changing their look, right? Because they don't want to be recognized, right? Well, viruses do the same thing, but instead of changing their hair color or cutting it all off or growing a beard or something like that, they change the protein spikes that attach them to certain cells in the body. Okay. So they mutate, and because they mutate, well, we're looking for a 5'10" male, blue eyes, brown hair. And what we have over here is a 6 foot blonde girl, so it doesn't look the same. So we don't trigger that prevention. Does that make sense? Viruses mutate very rapidly.
So then it'd be safe to say that a current COVID vaccine wouldn't be effective for the mutated virus?
So here's the thing about the current ones, and this is why you have to get boosters. We're always a step behind. So in the lab, they've realized, okay, this is what they look like now, and they create the vaccine for that. So they're constantly monitoring these changes in the wild, right? With people, they're constantly monitoring these changes and then creating that new set of instructions. But in the meantime, as they're rolling that out, because it takes time, it may mutate again. Now, in the beginning, it was mutating like crazy. Now it's kind of slowed down a little bit, and we see that with the flu as well. Now, here's the thing about viruses that most people don't know or don't understand. A virus is not a one cell fits all type of guy. He's just not. A virus will be programmed to invade very specific cells. So, like hepatitis, everybody has heard of hepatitis, right? Hepatitis is programmed, that virus is programmed to use the liver's cells. That's it. It doesn't use skin cells, muscle cells, stomach cells, intestine cells. It doesn't use any of that. It goes straight for the liver. That's the only cell it wants. It finds the liver cell. It invades the liver cell. And viruses don't need boy viruses and girl viruses to have baby viruses. Doesn't work like that. All they need is the right cell and the right environment, and they zip themselves in half, and now there's two. And those two strike off, find another liver cell, invade, alter. And by the way they do that is they unpack the nucleus of the cell, plug themselves in, and create a copy machine. They can't divide themselves without your DNA. So when they plug themselves in and they create a copy, they are altering your DNA. That's why we don't like viruses to run around unchecked, because they literally change the DNA of that cell. And that cell forevermore will be producing altered copies of itself. Now, imagine that on a big scale. That's why we were really concerned about COVID, because we understand what that virus is doing in the body. Okay, so hepatitis affects liver cells. Viral meningitis affects the lining of the brain cells. COVID affects endothelial cells. What are those? Endothelial cells are cells that line most of your organs and blood vessels. So this is why we had cardiac problems with COVID. This is why we had stroke problems with COVID. This is why it affected your ability to smell, because those endothelial cells, talk about worst case scenario, they're all over your body. HIV, as bad as HIV is, it affects one of your immune cells. Well, it's bad, but I'd rather have that than a cell that works on every single, because remember, it can only divide if it's inside the cell it's programmed for. So you got endothelial cells all over your body. You've only got one liver. So the pathogens have to work real hard to get to the liver. But with COVID, you got endothelial cells everywhere. So it provides a wide open opportunity for procreation for the viruses. Does that make sense?
It's a good
Okay.
explanation. It's clear, much more than I've ever heard before as far as the clarity of it,
Oh,
to be able to understand it.
yeah, I tried to make it like fifth grade, you know.
I appreciate that.
So well, understand that I am oversimplifying it, but the science is sound. understand the people that are studying it, they could literally write books on it. But that doesn't help you guys. If you're not a virologist, that information isn't going to help you. So we have to understand that the viruses that we are dealing with in a clinical setting, okay, they are going to target one specific type of cell. And viruses themselves are kind of hard to kill. So when we have somebody that is suffering from a virus, we're going to treat that a little bit different than somebody that's suffering from a bacteria. Bacteria are humans, or not here, I'm sorry. Bacteria are like humans. They're alive. Viruses are not like humans. They're just a protein. They are not alive. So how do you kill something that's unalive? And that's what makes viruses a little more difficult. Okay, they're a protein. We have to unravel the protein, which is a little more difficult. That's why it's harder to develop a good fight against viruses. Does that make sense? Good. There's way more viruses than there are bacteria. Like trillions to one. Trillions to one. So viruses are a much bigger problem in the microbe world. Good? Make sense? So we need to understand that even if something invades us, bacteria or virus, doesn't matter, we have to be susceptible to that for it to be able to take hold of us. If our white blood cells have already seen that pathogen and we have an instruction manual on board, they'll kill that pathogen before it ever has a chance to make us sick. No problem. So if you've got a good working immune system, and remember, your immune system needs to work out once in a while, so go have a sub. It's okay. As long as our immune system is in good shape, the pathogen won't be able to take hold. Good? Make sense? Okay. Having a healthy, trained immune system helps prevent the spread of infection. So this is where that whole self-care thing comes in. Make sure that you're getting appropriate sleep. Make sure that you're eating right. And your immune system relies on physical activity to stay in top shape. So, 20 minutes of exercise a day will help keep your immune system very good. All right. So remember, most pathogens need a home to survive. So just being on the surface in a clinical setting, there may be pathogens there, but they're not going to live very long outside the human body. Pathogens can't get through our skin. They have to be let in. So they have to find a portal of entry. Eyes, nose, mouth, genitals, rectal area, wounds, rashes, sores, or incisions. That's how the pathogens are going to get in. So if I'm just skin to skin contact, if I'm going to take your pulse, I'm going to reach over and take your pulse. I have intact skin. I'm touching intact skin. I don't need gloves for that. Pathogens can't get out of her skin. They can't get in through mine. I'm going to wash my hands before I ever touch her, because we never touch a patient until our hands are clean. So I'm going to touch her with clean hands. That keeps her safe. I'm going to do the skill, and at the end of the skill, we have to end skill with clean hands. So anything that my skin may have come into contact with her is down the sink. So did I need gloves? No. And if I wear them routinely, I stop paying attention to what those gloves are touching. And that's when I put her at risk. Good? Make sense? Starting to come together? All right. So this pathogen has to work really hard to spread. First of all, we have to have a pathogen. It's got to have a place to live. And then it's got to be forced out of that place to live. Then it's got to have a way of traveling to another person. And then that person has to have a doorway to get in. And that pathogen has to be brought to the doorway. Because remember, it can't move on its own. And then that person has to be susceptible. And if there's a break anywhere in there, the infection does not spread. So let's go back to COVID for a minute. When we had the very early stages of COVID and we were telling people to wear masks, we were trying to fix this. Okay. We weren't trying to prevent the pathogen from getting out. We were just trying to prevent it from coming into you, spreading around. Now, once we realized, okay, it's not really in the air, right? We can just social distance now. So that's when they started telling you stand 6 feet apart from other people because we knew it was droplet. So the more we know about a pathogen, the better we're able to direct people on how to prevent themselves from coming into contact with it. But throughout that whole thing with COVID, throughout that whole thing from day one, they kept telling you to wash your hands. Wash your hands. If you're not sure what to do, wash your hands. All of the big recording artists came out with, well, you can wash your hands to all the single ladies. You can wash your hands to, I don't know, there were like 15 songs that people were promoting to wash your hands because 20-second clip worked. We were told to wash our hands. Well, the reason that we're washing our hands is because it's breaking this chain of infection at the transmission part. If all the pathogens are down the sink, they can't get into anybody else. Good? Does that make sense? Okay. So remember that when they give you guidance, it's a lot of times in the beginning based on guesswork because we don't know yet. And then they will adjust that as they move forward based on the research that they're doing. And they don't always get it right. Don't always get it right. But it's better than having no guidance. Okay.
So as a nursing and we do so much with our hands, one thing that we should be aware is hand care for ourselves.
Right.
So,
We're
your cuticles and biting our nails down below where they're open.
very good. Very good. So we're going to talk about that in just a second. But yes, hand care for us is going to be very, very important because let's think about how many patients we have. Let's just go with our 12 that we were talking about earlier. Okay. And we're going to do bathing, dressing, grooming, feeding, all these skills with all of those patients. Now, not all patients need help with all skills, but let's just say that on average, we're doing about 10 to 12 skills on each of those 12 patients over our shift. Okay. So we'll do this easy. 12 skills on each of the 12 patients is 144 skills. That's a whole lot of skills, isn't it? Right? That's 144 opportunities for pathogens to get in or spread around. So that means that we're going to be washing our hands not 144 times, 288 times. Yeah, they're paying you an hourly wage to wash your hands, guys. So if we're washing our hands 288 times in the shift, whew, man, that's a lot of times. Your hands are going to get dried out. Soap is moisturizing, but it's not great. your hands will get dried out. Now, this is why most healthcare workers become jaded and they just stop washing their hands. Because I'm not washing my hands 288 times. I'm just not going to do it. I've got better things to do with my time. So they'll grab a little hand sanitizer, rub their hands together like this, and move on. Not thinking, they're thinking about themselves. Who should we be thinking about? The patient. Because hand washing is not really about you, it's about the patient. They're the ones at risk here. So when you start taking these shortcuts, when you aren't using the hand sanitizer properly, or you're skipping hand washing altogether, it's the patients you're really putting at risk. Remember, medical errors kill more people than heart disease every year. I'm giving you all the keys to how that's happening. We can do better. Does that make sense? So, I have a best friend. We have been best friends since we were 10. There's actually a group of 3 of us that were very, very close. But my best friend, she actually stayed with me last night because her AC was out. Poor thing. Horrible. So every year at Christmas, she gives me a whole bunch of high-end hand lotion, hand cream. And it's very expensive. But this has been her gift to me for at least 30 years. Every year at Christmas time, I get loaded up with lotion for the year. And thank God for her. So this stuff works really well on my skin. But it doesn't mean it's going to work on yours. You might find that Gold Bond lotion works fantastic. You might find that it's too watery for you. You've got to find what works for you and make sure that you're taking care of your skin. Okay. Does that make sense? 288 hand washings is going to dry out your skin. There's no doubt about it. O'Keefe's Working Hands works pretty good. There's something called Udder Cream. It's like in a little black and white, I don't know what you call it. Little black and white thing. Tub. Thank you. That works for some people. L'Occitane is what I use, which is a high-end French, I think it's French, lotion. It's what she gets for me. So everybody has something that works for them. Find what works for you and start working it into your daily habits. I'm very dry right now, so I need some while we're talking about it. So find what works for you. But you also have to think about, when we're talking about the chain of infection, remember, pathogens get in and out of skin openings. So if I have skin openings on myself, if I have a brand new puppy, he'll be 5 months old tomorrow, actually. Aww. But he is still very playful. He's still very bitey. And I get scratches on myself every once in a while from him. Now, if I'm working with patients in a clinical setting and I know I've got a scratch on the back of my hand, remember that will let pathogens in, but it will also let them out. So even if I were to take a pulse on you, skin to skin contact, nobody's really at risk here. I'm washing my hands before, I'm washing my hands after. But if I have a skin opening, I'm going to wear a set of gloves to protect her. Does that make sense? So now we're going to get into nails. Let's talk about nails for a second. Some of you guys like going to the salon and getting very nice nails done, acrylic nails, gels, whatever you're doing. There are some places that do not allow artificial nails. So that would be a good question to ask during the interview. What if nails are important to you? What is your policy on acrylic nails or artificial nails? Some places are really lenient on that. They do harbor bacteria, by the way, especially once they start to lift, because underneath that nail is warm, dark, and moist. Yes. So it does, pathogens grow like crazy underneath once they start to lift up. Whether they're gel or artificial, you will get pathogens under there. So you want to find out what their policy is on that. If you're a artificial nail person, and that may not be the right place for you, you may have to find a place that works for you. If you have hangnails that you pick at, that you pull, like I've got one starting here that I found myself pulling at. I have cuticle trimmers on me at all times, because if I pull it, I'll rip it. And when I rip it, there's an opening. And my hands do everything. I mean, they're everywhere. So a lot of your pathogens are going to come in through holes on your hands. So for me, this is a very convenient excuse to have to get a manicure. You can justify it. You definitely don't want skin openings on your hands. You want to try to minimize those as much as possible, because remember, your hands are going to be in everything. Anybody here ever wear rubber gloves? You ever wear rubber gloves? Okay, you know how when you take those gloves off, it leaves like that powder thing on your hands? That is designed specifically to be irritating to your skin, to force you to go wash your hands. Because most people, when they take gloves off, they think to themselves, I wore gloves, I'm safe. And they don't go wash their hands. I'm going to explain to you why that's important in just a second. I'm going to make you think about this a little differently. All right, so when it comes to preventing the spread of infection, don't let stuff from other people's holes into your holes. A great way to remember this is cover your holes. Cover your holes. Doesn't matter what they are. And yes, I'm talking about all of them. All of them. If you want to prevent the spread of infection, cover your holes. I'm going to have a t-shirt made at some point.
I'll buy one.
So gloves are just an extra layer of protection. Remember that your skin is the best layer of protection you have. Keep it in good condition. But gloves provide an extra layer if we're going to be working with wet body openings, like body fluids, personal skin, breasts and genitals, and non-intact skin. If we're going to be working with any of those, we need an extra layer of protection, which is gloves. But as we're using those gloves, we have to think about who they're actually there to protect. Are they there to protect you, the healthcare worker, or are they there to protect the patient? Yeah, because remember, you're washing your hands before and after. You're safe, reasonably speaking. So we have to think about those gloves from the patient's point of view. Does that make sense? Mm-hmm. Okay. So let's think about that sandwich for a second. So a question I asked about the sandwich when we were building it is, were those gloves effective? And the answer to that is, well, it depends. Who were the gloves being worn for? If the gloves were being worn for the customer, no, they weren't effective at all. They touched everything. But if the gloves were there to protect the worker from touching the condiments or the meat or the cheese, yeah, they were probably pretty effective. So when it comes to gloves, you always have to think about who are those gloves there for to determine whether they're effective or not. Good? Does that make sense? Okay. So remember, you're pretty healthy. Keep your immune system on standby by taking care of yourself. But your patient has an immune system that's currently busy. They're fighting something off. They are ill or injured. If they weren't, they wouldn't be here. And this is where we have most of the pathogens in a clinical setting. So if we bring the patient another pathogen, their white blood cells who are currently busy aren't going to have the resources to fight off that new thing. And that new thing is probably what's going to cause the biggest issue. Good? Make sense? So one of the stories I always think about when I'm talking about this particular topic, a couple of years ago, it's probably maybe even 10 years ago now, there was a woman who this was absolutely horrible. She went in to have an MRI done, I think like of her head or something. I mean, but when she was in there having the MRI done, there was a part of the MRI machine, might have been a CT scanner, I'm not sure, but she was having a test done. And there was a part of the machine that was sticking out and it cut her leg, just a little scratch on her leg. No one really thought anything about it, just a little scratch on her leg. Well, she ended up, that had a flesh-eating bacteria on it, and she ended up losing her leg all the way up to the hip. So, I mean, she went in for just a routine test and she lost her leg. But not just that, she lost years of her life fighting the infection. She couldn't work. Fighting the infection, all of the medical procedures, it cost her a fortune. And then she lost her leg. I mean, that's horrible, right? So we have to consider that even small breaks in the skin can have disastrous consequences when we're in an environment that has that many pathogens. Good? That makes sense? I always think about her. I feel so horrible for that. Now, why is this important to us? Well, as CNAs, this is what we do. ADLs. We talked about this on Monday. Bathing, dressing, grooming, feeding, toileting, mobility, right? This is our wheelhouse. This is what we do. Think about all the body openings we are around. Feeding, mouth care, right? That's all here. Bathing, you're going to bathe the face. Pericare, you're working with the genitals. Helping patients that have wounds. We are around doing ADLs. We are around body openings all day long. So it's really important that we, out of everybody else, all the other people that are taking care of these patients, this is way more relevant to us. Got it? Because we're around those wet body openings all the time. The nurse may not have any contact with the patient's eyes, nose, mouth, or genitals on this shift, but we do. So we've got to get this down. Okay? Good? Bathing, feeding, mouth care, denture care, peri-care, catheter care, toileting. It's all us. And remember, any doorway that can let something out can also let something in. So gloves provide an extra layer of protection for the patient too. And remember that that's a big reason why we're wearing gloves. And remember, pathogens need doorways to get out of and fluids to travel in. So this brings us to our first rule for glove rules. If we're possibly going to touch any body openings, personal skin, or non-intact skin, we need an extra layer of protection. Okay? So that's even a maybe. If I'm going to put my hands under somebody and they're not wearing undergarments and I'm not entirely sure they didn't leak something, I'm going to wear some gloves. Remember, you can't tell by looking at somebody whether they're sick. We don't have that capability, right? There's no LCD screen on my forehead that says that I have hepatitis C. Man, it'd make medicine a whole lot easier. Make medicine a whole lot. If you could just walk through like an airport scanner and it can tell you exactly what's wrong with you, awesome. That's cool. We don't have that. So I can't tell by looking at somebody what they have. I've got to treat everyone as if the stuff coming out of their bodies is potentially infectious. This is called universal precautions or standard precautions. It means I treat everybody as if they have a pathogen. Let me show you how serious I am about this. Years and years ago, when my oldest son was about 18-ish, he and his dad went to do a job down in Fort Myers, and they were taking down a whole bunch of stuff inside a retail store. And I guess a piece of slat wall or something slid down his leg and took a whole bunch of his skin and muscle and stuff and took it right down to the tendon. So my husband calls me and says, what do? I gave him instructions, how to clean it, how to wrap it, bring him home to me. So they come home, long ride. They come home. I get him sitting down and I put on a pair of gloves before I unwrap the bandage. And he says, Mom, why are you wearing gloves? It's me. I said, yes, and I love you dearly, but you have been out of my sight for more than 15 minutes. And I don't know what has gotten into any of your holes. So I am wearing gloves. And you should too. Now, if I'm wearing gloves with my son, whom I dearly love, you can absolutely bet that I will wear gloves if I'm going to work around any body openings on a stranger. Okay. When I say don't let stuff from other people's holes into yours, I mean it. All right. So anytime we're going to touch body fluids, personal skin, or non-intact skin, we're going to have an extra layer of protection. We're going to use some gloves. And this applies to everyone, whether we know they have a pathogen or not. It's standard precautions. All right. But if we're going to use gloves, if we've decided that this is a good idea and we're going to use gloves, then the first thing those gloves should touch is the patient. First thing your gloves should touch is the patient. So I'm not going to put gloves on and get my supplies. I'm not going to put gloves on and close privacy curtain. I'm not going to get gloves on and pull the sheet down. I want the first thing to touch to be the patient. Because if I touch the bed and then touch an open body area, I'm going to transfer pathogens to that doorway. So if we wear gloves, what's the first thing we touch with the gloves? The patient. Now, once we've touched the patient and we're all gunked up and it's time to take our gloves off, the way we take them off matters. Ooh, oh, did you hear that? Ooh, snap, crackle, pop. I am Rice Krispies today. All right, so let me show you how to remove gloves. Now, these gloves are up here. You guys have, during break, we're going to take break in just a little bit. You can grab a set of gloves and practice with them. So if I have gloves and I put them on, then I do what I need to do with my patient. And now I'm all pathogened up, right? My gloves are soiled. I have to take them off correctly. Glove can touch glove. This is fine. Glove cannot touch skin. So I cannot go underneath. And that's a very common mistake. You don't want this dirty glove to go against your skin. So in order to take this off, I'm going to pinch up here at the palm. So I pinch up and pull that off. So it's inside out. I'm going to wind it up in this hand so it's not waving around. I want to keep control of it. Now, skin can touch skin, but it cannot touch dirty glove. So I can't pinch up here. For this one, I have to go underneath. Pull that off, inside out. So I have one inside out glove inside the other inside out glove. Okay, good. So we pinch up, pull off, go under and pull off. The order matters. If you wear gloves for the test, for any of the skills, you are graded on glove removal. Okay. Good? Am I going too fast? So we want to make sure that we remove our soil gloves correctly. So now let me dispel some myths that you may have about glove use. I always surprise people by this. Gloves are not the magic suit of armor you think they are. They are not. They do not protect you the way you think they do. So I'm going to prove it to you. You ever seen balloons like this? These little latex balloons? You have them filled up with helium. They bop up against the ceiling for a couple of days. They're made out of the same stuff as your gloves, latex. Okay. But after a couple of days, what happens to that balloon? Yeah, it deflates. It shrinks. It gets smaller. How does that happen? What's that?
Little tiny holes in the gloves.
Little tiny holes. That is
Not
correct.
the gloves in the balloon.
Yes.
In the latex.
Latex is a man-made material, and it has teeny tiny microscopic holes. You can't see it. But if you put it under electron microscope, you can actually see the little holes in the fabric. It's just like your uniforms, right? Uniforms look solid, but if you hold it up to the light, you can actually see light coming through the weaving, right? So think of it like that. Now, these holes are microscopic. I mean, they're teeny, teeny, tiny. But viruses are teeny, teeny, tiny. Now, over time, when this balloon is inflated, okay, those teeny, tiny holes, as the fabric of the balloon stretches, what happens to those holes? They get bigger, and the helium wiggles out through those holes. Now, if helium can wiggle out through those holes, viruses can certainly wiggle out through those holes. Now, they've done 1 million studies on this. It's actually one of the favorite studies to do in microbiology class. They will have people wash their hands really good. People that work in healthcare wash their hands really good, put on a set of gloves, go work on a patient. And when they take those gloves off, they will culture their hands every single time. Every time. The culture comes out positive. Pathogens get through these holes. So that should tell us that gloves do not do what you think those gloves are going to do. Now, if you ever wear gloves, what does it make your hands do? Sweat, itch, yeah. It holds in body heat, blocks out light. So we have warm, dark, moist. Yep. So pathogens that get through the gloves onto the surface of your hand has what it needs to procreate. So when you take those gloves off, if you don't wash your hands, you just have a whole heaping handful of whatever pathogen this patient is playing with. Now, every once in a while, I'll go to a big box store, and back when they had cashiers, now they make us do it. But back when they had cashiers, you would see cashiers with gloves on, scanning your stuff. And I always want to explain this to them, but I don't have time at the checkout. But, little Mary will be scanning all of your stuff because they don't want to touch your ketchup bottle. They got gloves on. They'll scan, scan, scan. And at the end of her 4-hour shift, she'll take her gloves off and think to herself, my hands are clean because I wore gloves. I didn't touch your ketchup bottle. And they'll go to the break room and they'll eat their tuna salad sandwich with a side of E. coli. And they wonder why they get sick. Well, they got sick because, number one, the concentration of pathogens under that glove is pretty high. You wore it for 4 hours. And number two, if you had not worn gloves, you would have washed your hands. So gloves provide a false sense of security. Be careful. They are a good additional barrier, but they're not a magic suit of armor. Does that make sense? Be careful. Little bit of information can be very dangerous. So pathogens will go through that hole. Now, remember I said there's two things that affect this, time and stretch. That balloon held helium for a while. Time. So we want to wear gloves for the shortest time possible. And stretch affects this too, because the more you stretch something, the bigger the holes become. So you want to make sure that you're selecting gloves that you're not forcing your hands into, that fit appropriately. Okay, good. All right, remember they make you sweat. So if pathogens got through your gloves onto your hand, you want to make sure that you wash them. We've already gone over glove removal. So here's a picture that shows you how gloves are removed. You pinch up at the base of the palm of the first hand, pull it out inside out, and then go underneath the cuff of the second hand and pull that inside out as well. All right. So any questions on glove rules? There's one more reason that you don't want to wear gloves all the time when you don't need them. Guys, I'm not an environmentalist at all. I drive a gas guzzler. I like it. Okay, I like speed. I am not an environmentalist. But this kind of hit me. When you put on a pair of gloves and you take them off and you put them into that trash can over there, you never think about what happens to them beyond that. Right? We use them, we throw them away, we don't think about it. Well, we need to think about it. Latex gloves are biodegradable. They do break down eventually, but it takes a very long time to break them down. But we don't normally use latex gloves in healthcare anymore because so many people have a latex allergy. I'm probably turning red right here, like, because I can feel it inflaming. I'm developing a latex allergy because I've worn gloves so much. And when I get anything on my face, I start to break out. So that's very common. The more exposure you have to latex, the higher your likelihood of developing a latex allergy is. So in healthcare, we usually use vinyl or nitrile gloves. Those do not biodegrade ever. That means that every pair of gloves you put on is going to be on this planet 100,000 years from now. So, like I said, I'm not an environmentalist. In like 30 years, I'm out of here. You know, not going to be here long enough for this to matter to me, but it will matter to my daughter or my granddaughter. Because in healthcare, just in America, I'm just talking the US, not even talking worldwide. Just in the US and just in healthcare, not manufacturing, not food service, just healthcare. We fill a stadium 35 feet deep with gloves every single day. Now, remember, we're not the only ones that use gloves. Manufacturing, housekeeping, food service. I'm just talking about healthcare. So you can quickly see that it doesn't take a genius to kind of think this through a little bit further down the road. And we are going to have gloves coming out of our ears. We can't burn them because that created a hole in our ozone layer. We did that in the 80s. We burned everything and destroyed our ozone layer. And somebody said, oops, that's a problem. Quit doing that. So we quit burning the stuff. Now we just kind of stockpile it. We put it in a landfill somewhere and hope somebody's going to come up with an idea. Well, somebody did about 20 years ago. And they said, you know, we have this big ocean out there. Nobody's using it. Just kind of wastes space. So they put medical waste in big metal drums, poked holes at the top, drug them out to the middle of the Pacific and dropped them in. The holes filled up with water. They sank down, created an artificial reef. And that worked pretty good for a while, but now the fish that we're pulling out of the Northern Pacific has high levels of latex in the meat. We poisoned our own food supply. So now they've decided that's not a good idea. Let's not do that. So we're back to stockpiling again. So this isn't my problem. Not going to really affect me. But those of you that are younger, this is a problem. And it will affect you. So we've got to be a little bit more judicious as to when we decide to wear gloves. Does that make sense? Just a little food for thought. All right. So we're going to stop here and take our break. Come back at 20 till, and we will get into skills.
I didn't know which way you were going. Okay.
Thank you. I had an email. I had to check my time. Well, I am late when it comes back to the black screen of death there. All right, so just to review glove rules, we're going to use gloves if we might touch wet body openings or body fluids, personal skin, or non-intact skin. So when you go to start a skill, any skill that you're going to do, you want to ask yourself those three questions. During this skill, could I potentially touch body fluids? If the answer is yes, you need gloves. If the answer is maybe, wear gloves. If the answer is no, move on. During this skill, is it possible that I might touch non-intact skin, wounds, rashes, sores, incisions? If the answer is yes, you need gloves. If the answer is maybe, you need gloves. If the answer is no, move on. Am I going to touch personal skin? So skin normally covered by a bathing suit. You don't want to touch personal skin with bare hands. It's just a little too personal. Okay. So if the answer is yes, you need gloves. If the answer is maybe, you need gloves. If the answer is no, you won't need gloves. Good? So we're just going to go through those three questions in our head for every skill that we do. If you do wear gloves, the first thing they should touch is the patient. Make sure that you remove them correctly, but also pay attention to what you're touching in the environment. I see this a lot in healthcare. Your shoe is untied. I see this a lot in healthcare. Nurses will walk in a room, they'll put on a pair of gloves, they'll close privacy curtain, they'll change a dressing, they'll pour the patient a cup of water, they'll hand it to the patient, all with those same gloves on. They stop paying attention to what they touch in the environment. We wouldn't want to touch that cup and hand it to the patient. Good? Make sense? Okay. All right, so let's talk about pulse. So let me go back here. If you go to page 52, we've already seen this page. These are the principles that are involved. We now know glove rules. So we're going to focus on pulse specific rules now. You go to page 53, look at top of 53. You'll see the care plan at the very top of the page. It says a patient is laying in bed for this skill. Count the radial pulse measured at the wrist for 1 full minute and record your readings. That's your care plan. That's the testing care plan. That's exactly what it's going to say if you get the skill for the test. So looking at this, how long do we have to count? What if we want to shortcut this? What if we just want to do 15 seconds and multiply that by 4? Can't. So for this patient, for whatever reason, we don't need to know the reason. For whatever reason, the nurse needs a 1 minute count. So for the test, if you aren't counting for 1 minute, you will fail. Doesn't matter what number you get. It's not about the number. It's about
following the directions. So think of this as a giant game of Simon Says. Simon said, count for 1 full minute. If you don't do what Simon says, you're out. Okay, good? Make sense? Okay. All right, so let's talk about what a pulse is. Now I got to get up. Bear with me, guys. I'm going to moan and groan for a minute. All right, let's talk about what a pulse is. So you have a heart on the left side of your chest. That heart squeezes. When the heart squeezes, it pushes out a wave of blood. That wave pushes the one in front of it. That wave pushes the one in front of it. And that's how blood moves through your circulatory system. So if I were to cut a hole into an artery and put a viewing window there, you would see a wave move through and then a valley. Anybody ever go to a wave pool at a water park? Okay. You know how it's a wave and then a valley. And then the next wave comes and it's a valley. That's what's going through your circulatory system. Waves and valleys. Good? So if you understand that, what we're going to do is take 2 fingers, push down on the artery so we can feel those waves. If we count the number of waves, we know how many times the heart beat. Because remember, when the heart beat, it produces a wave. Count the waves, you know how many times the heart beat. That's all we're doing here. That's it. All a pulse is counting how many times the heart beat while we were measuring. So you're going to feel this as a thump under your fingers. As a thump. We never use our thumb to take a pulse. Your thumb has its own artery. It's actually a fairly decent size artery. Get rid of that. Fairly decent size artery. And if you press down on that artery, you can actually feel your own pulse. So we don't want to do that. We never use a thumb to take a pulse. That could be a written test question. Which finger should you never use to take a pulse? Thumb. Generally speaking, we use our index and middle finger. But when we do this, we want to use our fingertips, not the flat part of our fingers, our fingertips. You've got way more nerve endings here than you do here. So to be able to pick up that feeling, remember, it's what we feel, we're going to use our fingertips. So we're not using our thumb to take the pulse, but that thumb is still going to do a very important job. And I'll explain that in just a second. But in order to find a pulse, the pulse is located at the top of the thumb side of the wrist. Let me show you on this one. So this is my thumb. This is the bendy part of my wrist where the lines are. I don't take a pulse up here. I need to be right here where the hand and the wrist meet. Way up here at the lines on the thumb side. Now you do have a pulse down here, but that's not the one that our care plan told us to use. Our care plan said radial pulse at the top of the wrist, okay? So in order to find your pulse, you're going to 2 fingers, fingertips, not flat. In order to find your pulse, the easiest way for new people is to put your hand out like you're going to shake hands with your thumb pointing straight up. Take your fingers and stand them up on the bone. You've got a bone that runs right there. Stand them up on the bone and then, like straight up, and then roll them forward like you're diving off a cliff and put your thumb on the back. And you will find the pulse. What you're doing is pushing that artery right up against that bone. And you should feel thumps under your finger. Everybody find your own pulse? Now, if I put my fingers here, I'll feel the pulse, no problem. But over time, my fingers are going to relax. I can't help it. It just happens. So in order to keep my fingers consistent where I don't lose the pulse, I'm going to put my thumb on the back side. When you put your thumb on the back side, your fingers form a C that holds consistent pressure and you don't lose the count. Good. Everybody find your pulse. Do I have any dead people in here? No dead people? Okay. So again, we want to be way up here. So we're going to go right there. Put your thumb on the back. Okay. You're welcome. Good. All right. Find somebody else's. Grab a hand and find a pulse. You don't have to count. Just find the pulse. Just find the pulse. You don't have to count. One, two, three. 1, 2, 3. 1, 2, 3. 1, 2, 3. Okay, good. Did everybody find a pulse? Okay, so when you're trying to find a pulse, you're going to start out kind of light. You don't want to just clamp down really hard because when you do that, it's like a straw. Where's my drink here? If I have a straw and I pinch that straw, nothing's going to get through. So if you press down too hard, nothing gets through. You're not going to feel the waves. So you start light. If you don't feel anything, press a little harder. If you don't feel anything, press a little harder and just gradually increase the depth until you pick that pulse up. Okay? Too much pressure will actually obliterate the pulse. Normal is between 60 and 100. So if I'm counting the pulse and I get 62, that's somewhere between 60 and 100. That's normal. If I'm counting the pulse and I get 56, is that normal? What do you think I should do with an observation that I made? Tell the nurse. So I'm going to write it down. I'm going to document it. And then I'm going to go tell the nurse, hey, the pulse is 56. And let them figure out what to do about that. I'm not going to sit there and think to myself, oh, well, he just ate and maybe that's why the pulse is slow. Or he just had his beta blocker and maybe that's why the pulse is slow. Or he hasn't really gotten up and moved around a lot. Maybe that's why the pulse is slow. I don't get to make those decisions. That's the nurse's job. Okay, good. Questions? What do you think I should do if I get a pulse rate of 112? Yeah, tell the nurse. And that would be more of a let's go get the nurse now situation, not in a little while. Okay, good. Now, I'm going to give you a little nugget of wisdom. If your patient has a high pulse rate, look at their blood pressure. If they have a high pulse rate and a low blood pressure, that patient is most likely experiencing some sort of shock. And that needs to be reported 2 days ago. Okay. Like right now, that is emergency. So what a lot of people don't know is when you get an infection, your body has to fight it, right? So everything is working on fighting that infection. It's a very busy time for your body. Well, when we have so many resources going into fighting the infection, sometimes our body organs don't do what they're supposed to be doing because all of our energy is going into fighting the infection. Good? Makes sense? This, when we end up with pulse and blood pressure problems because of an infection, it's the first sign of septicemia or an overwhelming infection that has spread to the blood. This is called being septic. Has anybody ever heard that term? Being septic can kill you fast. And unfortunately, the big signs of septicemia or being septic don't show up until usually it's kind of too late. But CNAs that know high pulse rate and low BP, danger, danger, danger. If you remember that high pulse rate, low BP, you guys can actually save their lives by reporting that. High pulse rate, low BP. It's the first sign that the patient is going septic. And if we can intervene then, wow, we could save a lot of people.
That actually happened to me.
Really?
I had internal that I had strep.
Oh, yeah. Yeah, people think that strep is like, you get a sore throat, you get some antibiotics, you're fine. Strep is nasty. It's a bad bacteria.
My airways were blocked and
Oh,
fever. Blood pressure on my pulse was like, I think it was like 135.
yeah. Yep. Scary. I'm glad you recovered well.
Yeah.
So you may have a test question about that. Which vital signs would you report immediately? Look for one that's high pulse, low BP. Okay, good. Good. Okay. All right. So when we are taking a pulse, let me back out of the way here real quick. When we are taking the pulse, the elbow needs to be supported. So remember, our care plan told us our patient's going to be in bed. So when you're taking the pulse, just make sure the elbow remains on the bed. Don't lift their arm up like this. Let me explain to you what happens with this. If you're taking a pulse of somebody that's standing, don't have them have their arm out like this. The arm needs to be relaxed. When I have my arm out like this, sitting, standing, whatever, if I hold my arm out like this, and you can try this on your own. If you hold your arm out like this for a minute, it starts to get heavy. Your muscles have to engage to keep your arm out like this. When you engage your muscles, they require more blood flow. Since they require more blood flow, the pulse speeds up. So if you have the arm out here, are you getting an accurate reading? Isn't that crazy? Isn't that crazy? So an important part of this skill is actually having the arms supported on the table, on the bed surface. With your hand, that's fine, but that elbow needs to be supported so those muscles don't engage. Okay, good. All right. So our care plan is very specific. Question I get asked a lot is, how long do you count? Well, we follow the care plan, and our care plan here tells us 1 full minute. So the short answer to this question, how long do you count for? As long as the care plan tells you to. If the care plan says 1 full minute, we'll count for 1 full minute. If not, we can use a shortcut. If the care plan doesn't specify, we are allowed to use a shortcut. Now, those of you who don't know how to read one of these clocks, go to YouTube. They've got a million tutorials. But this is just a regular, what we call analog clock. 1 trip around is a minute, right? 1 trip around for the second hand is a minute. So if you divided this up into 4 quadrants, this one is 1, 2, 3, and 4. Each one of these quadrants is 15 seconds. So if you count it for 15 seconds and then multiplied that by 4, you get a whole minute. So that's allowed. You can do that. You can count for just 15 seconds, multiply that by 4, and you still get your minute reading. We can't do that if our care plan tells us to count for 1 full minute. Good? Make sense? So what do we follow? The care plan. But know that this is an acceptable, perfectly acceptable shortcut, as long as the care plan doesn't contradict it. Okay, good. All right, so on page 53, you've got step-by-step instructions. This is my 42-step peanut butter and jelly. Very detailed. Requires you know nothing but your own name. If you just follow these instructions, you will perform the skill perfectly. So when you're home practicing, you can send a live human over to a corner with this book in their hand, open to this page, and tell them to read you the steps. And when they read you the steps, you do them. This way you know you're practicing right. Okay, good. Good. All right. So a couple of things that we want to remember when we're doing this skill is that we're always going to support the arm at the elbow. We're not going to use our thumb to take the pulse. We'll use fingertips, not the flat area. The radial pulse is at the top of the thumb side of the wrist, near the bone. We're going to follow the care plan for how long we count. Normal values are 60 to 100. When we count with the evaluator for the test, we're going to say start at the beginning of the minute and say stop at the end of the minute so that they count for the same amount of time that we count. Good? Good. Now, in Florida, we have 2 RNs. We talked about that on Monday. Each one of them has to grade you independently. We talked about that on Monday. Since both of them have to grade this particular skill, they're going to be on one side of the patient. You're going to be on the other side of the patient counting the pulse. So you find the pulse, you look at the clock, you say start, and both of you guys are going to be counting the same thing because remember, those waves are created by the heart squeezing. So it doesn't matter if you're on this side or this side. It's only one heart. Okay, good. So you're going to say start out loud. You're going to count for that whole minute, and you're going to say stop. And you're going to write down that answer. And then the evaluators are going to switch places, and they're going to say, count with me now. Because remember, they have to grade you independently. Okay? They'll tell you what to do. Just follow it. They don't make you wash your hands before you document that one because you wouldn't be counting with another person in a clinical setting. That's just for the test. Good? Okay. So, everybody stand up. We're going to play a little musical chairs here. I want you to stand behind your chairs and push them in, please. All right, I'm going to ask you to come stand right here. Let's see here. I've got, see, I'm going to ask you to come over here. And I'm going to ask you to come over here. Try not to bump the camera. Okay, come on in here. No, you're fine. You too, come in here. Okay, you're going to face those 2 ladies. You're going to face these 2 gentlemen. All right, so come in here. And you come out here. And then, what's your name in the teal sweater? Amy. Amy, please come on in. Come over here in the middle here. Both of you ladies in the middle. Come on over here. There's a method to my madness, I promise. Okay, so yep, you're going to face these 2 ladies. I need you to come over here, and you're going to face these 2 ladies. So I now have groups of 3. Everybody see I just put you guys in groups of 3? Okay, so you 2 and you're a group of 3. You 2 and you are a group of 3. You guys are a group of 3. You guys are a group of 3. You're a group of 3. And it's a big class. Okay, the single person, the person that's alone on the side of the table. So you, and you. You are the patient right now. And you're going to put both of your hands out. Now, I know I told you not to have the arms, so don't worry about that right now. But you're going to put both of your hands out and you're going to find the pulse on the hand closest to you. You're going to find the pulse on the hand closest to you. You don't have to count. Find the pulse on the arm closest to you. Remember that you don't want to use your thumb. When you have the pulse, I want you to say yes.
Yes.
Do I have anybody who does not have the pulse? Everybody good? When I say start, I want you to count the thumps you feel underneath your fingers until I say stop. Okay? Everybody ready? Ready? Oh, give me a second here. Set. Start. Quietly in your head. Stop. What'd you get?
Got 89. 90.
Okay. Okay.
73.
Okay.
73.
Okay.
79.
75.
65.
Okay. So the people were my two people on the same side of the table. You were the evaluators. Okay. So one of you counted, the other one verified. You guys see how that works? That's how it's going to work for the state exam. Now, we're going to switch partners. You guys can stay where you are, but one of the other two people, you are now the patient. Put your hands out. Put your hands out. So, yep. So you'll do that arm. You'll do that arm. Very good. Remember, it's at the thumb side, not the pinky side. Thumb side. You can use, are you right-handed? Okay, hold on one second. Nope. So let me help you. You're good. Go ahead and find it on that side. So you're right-handed? Go over. There you go. Thumb on the back. Okay, everybody good? When you have the pulse, say yes. Anybody not have the pulse? Okay. Excuse me. Got it? Anybody not have the pulse? All right, here we go. Ready, set, start. And stop. Okay, what'd you guys get? Okay.
79.
Okay.
Did you really?
What'd you guys get?
61.
Okay, good.
I got 68.
69.
Okay. All right, last person is now the patient. When you have the pulse, say yes.
Yes. Yes.
Not yet? Okay. Let me know if you need me. Got it? Everybody good? Ready, set, start. Stop. How'd you do?
65.
92.
Okay. What'd you guys get?
70.
90. Okay.
I think this is my
Okay.
Yeah, yours kinda hard to find that.
Okay. What'd you guys get? Okay. Go ahead and have a seat in your normal seats. So I want you to think real quick to when you were the patient for this. When you were playing the role of patient, how long did that minute feel? Oh my gosh, it's forever. And remember, your patients already think they're dying. Now, when you count a pulse and it takes that long, your patient will automatically think there's something wrong with me. What's wrong? What aren't they telling me? They're keeping secrets. So if I'm going to count for a full minute, I'm going to let my patient know beforehand so they don't freak out on me. Because do you know what anxiety is going to do to a heart rate? It's going to elevate. That's right. So if you are counting and it's like bump, 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 your patient is anxious. Okay. So I try to avoid that. I'll tell my patients, okay, this is going to take me a full minute to do. So just relax. I do need you to remain quiet, but I'll let you know as soon as I'm done. Then you can count for like 3 hours and they'll be okay with it. All right. But if you don't warn them that you're counting for a full minute, this can really backfire on you because you're not going to get an accurate reading. Does that make sense? Any questions on pulse? No? Everybody good with that? Do you understand what a pulse is? It's an indirect measurement of the heartbeat. So, ways that this skill are failed for the state exam. Okay, most common ways that this skill is failed. Number one, not counting for one full minute like the care plan told us to. That's survey says number one. The second reason is because sometimes for the test, people try to get fancy. Test isn't about being fancy. Test is about following the care plan. So there are some people that will go into test and they'll take their stethoscope with them and they'll pull the stethoscope out and they'll listen to the heartbeat and count that. It's called an apical pulse. It is a pulse rate measurement, sure. But is that what our care plan told us to do? What did our care plan tell us to do? Radial pulse. So are we following the care plan? These people fail and they have no idea why. No idea why. But they do fail. And it's not because they got an inaccurate reading. It's because they didn't follow the care plan. Starting to see how important this thing is for the test? Good? Questions? Don't use your thumb. All right, let's go to page 102. So this is our second skill. We just did pulse. This is skill number 2, dressing a resident. Now, if we were testing, we would wash our hands for pulse, take the pulse, and at the end, we're going to physically go wash our hands because that's skill 1, and we always wash our hands during skill 1. But for the test, before we go into skill 2, they're going to tell us you can simulate hand washing now. Simulate means say. So if this were my second skill, I would not actually go to the sink and wash my hands. I would just say when I was going to wash them. You guys see how simulation works? Now, the video that I'm going to show you is simulation is covered or is shown in that video. So in just a few minutes, I'm going to show you the video for dressing. Okay, good. You guys understand simulation? All right, so this is dressing a resident, page 102. If we look down the side here, we can see that there's a whole lot of principles that are going to govern how we do this particular skill. They're all spelled out for us here. And now I feel the anxiety going up because there's a lot of steps here. If you do every single one of these steps, you win. A lot of steps there. I get it. We have a video for this, which I'm going to show you in just a few minutes. This is a short version. This is test-specific instructions. Down here, it's going to give us testing information. Somebody with your level of experience should be able to do this skill in 14 minutes or less. You're dressing a mannequin. Does not take 14 minutes to dress the mannequin. Now, me getting ready in the morning, it might take me 14 minutes to get dressed because I'm trying to figure out what I want to wear. But the physical act of putting that clothing on, 2 minutes, I'm out the door. Good? Make sense? They give you way more time than you actually need. So don't rush. Do not rush. Got it? This is going to be done on a mannequin because we're not asking any of you to undress. That mannequin is going to be positioned already in the bed. And charting is not required for this skill, not for the test. Now, I do want to talk to you just a minute about this, positioning in the bed. So I want you to think of those evaluators kind of like the directors of a play. So the directors are going to make sure all the scenes are in the right place. The characters are where they're supposed to be. Everybody has their lines, right? That's what the evaluator's role is here. So when you go in to take the test and you're a patient, the evaluator is going to give you very specific information. I need you to sit in this chair in front of this table. I need you to lay down on your back in the bed. They're going to give you very specific information about where you need to be and how you need to act. You're going to follow that. So when you have pulse first, patient is in bed. It's a live patient. So you would have been over there in that bed for that skill. Skill number 2 is dressing a resident with a weak arm, and that's going to be on a mannequin in the bed. So we already have one here. This scene is already set. The evaluator would tell you, there's your patient. Do you guys understand that? Now, I give you all that information, so when you're practicing, you know who to practice on and where they should be while you're practicing. So I'm giving you that information to help you with your practice and to understand what's going to happen during the test. Good? All right. So if we look at that listing of all the principles that are involved in this skill, we know skill rules, we know the opening, we just learned glove rules, and we know the closing. So there's 3 more here that we have to learn in order to do this skill. I'm going to go through this somewhat quickly because these are all pretty easy principles to learn, but you will be seeing all of these again in future skills. So we're going to review them on Monday. You're going to see them again on Monday and again on Wednesday and again the following Monday. So if you don't get all of this right now, it's okay. It's coming back. Good? But they're pretty easy. So let's start out with barrier. This is going to be on page 84. Anytime we use supplies, we have to have a place to put those supplies, and that means that we need a barrier. So this is actually going to be featured in a lot of different skills that we do, like assisting a resident with a bedpan, denture care, catheter care, dressing a resident, drainage bag, foot care, hand and nail care, mouth care, occupied bed, partial bed bath, peri-care, and supported sideline position. You're going to see this principle in all of those skills. Good? Questions? Okay. I do have a video on barrier rules if you want to watch it. We talked earlier today. I need to turn this just a little bit. Earlier today, we talked about that table, right? This table. And I said it's probably going to be covered in all kinds of patient stuff. And we're going to have to carve out a space for us. Well, okay. So when you carve out a space and you empty the table, for the test, the table will always be empty for you. But when you carve out a space in real life, we can't assume this table's clean, right? There's a whole bunch of stuff just on it. We move the stuff, but the table still isn't clean. So in order to use this table for our supplies, we have to have a way of cleaning it or making it clean. Remember, the biggest threat to a patient is the pathogens in the environment, right? So if I've got this table all cleaned off and ready to use for a skill, it doesn't mean it's clean. So I've got to put something on this table to separate the table surface from my clean supplies. Remember, our patients eat on this. It's got grape jelly from breakfast. It's got brown gravy from last night's dinner. It's got all kinds, boogers from the Kleenex. It's got all kinds of stuff on it. So we're going to use a very specific kind of barrier. A barrier just means a separator. That's all a barrier means. I can use anything as a barrier. I can use a bath towel. I can use a paper towel. I can use a washcloth. I can use a Kleenex. I can use anything as a barrier. But for the test, we're going to use something very specific. This is called a disposable underpad. It's waterproof and absorbent. And when we put it on the table, we put it on so the absorbent side faces up. That way, if anything should spill on it, it's not going to go through onto the table. So absorbent side facing up. When we put this on now, I have a clean area for my clean supplies and nothing's going to leak through onto the table to contaminate anything later. Does that make sense? So this is called a disposable underpad, and this is what we're going to use for the test. They come in all kinds of colors. You'll see mint green, tan, blue, doesn't matter. If you go to the dollar store, you can get ones with little puppy bones on them because they're pet pads. But you can get these to practice with. That's fine. But I want to show a distinction, though. This is a disposable underpad. Now, in healthcare, everything has at least 2 names. Everything. I don't know why, but everything has at least 2 names. So this is called a disposable underpad, but its other name is a chucks because it's the kind of underpad you chuck after you use it. Think about all the syllables. Disposable underpad or chucks. In healthcare, we like to save time. Chucks. Now, this is a little bit different from a regular underpad, though. This is a washable and reusable underpad. And this has an absorbent side, has a waterproof side, kind of the same color, but this is washable. A washable underpad. Again, a lot of syllables. So this one we call a bed pad. Chuck's bed pad. Good? Questions? No? All right. So let's talk about when we get these things. So remember that every skill we have to read the care plan first, tell us what to do, which we're going to do in a minute. And then we're going to do our opening. Hi, Miss Jones. My name is Patty. I'm your CNA today. I'm here to get you dressed. Is that okay? I'm going to close your curtain and go simulate hand washing. Okay. I would wash my hands here. Now I'm going to get my supplies. But when I get my supplies, the first thing I'm going to get is this barrier. I'm not going to get the rest of my supplies yet because when I start working, my uniform is not considered clean. It leans against the bed. It brushes up against the curtain. It leans against the sink. It kneels on the floor to do foot care. My uniform is not clean. So if I get the patient's clothes that I'm going to put on them with the barrier at the same time, and I come over here, in order to spread this out, okay, so I've got clothes. We'll pretend this is clothes. I've got clothes, and I've got an underpad, a barrier. In order to spread this out, I need two hands. So what would I do? Something like this. My uniform is not clean. So what did I just do to these? Yeah. Guys see that? So it's hard to spread this out just with one hand. So we go get the barrier first before we get any of our supplies. Go get the barrier first. We bring it over, we unfold it, and then we go get the rest of the supplies that we need. Good. Questions? We don't want those supplies to touch our uniform. So real quick review, the table is used for meals and everything else. It's not clean, but the supplies we use for patients are. Since we need a clean place for our clean supplies, we need to use a barrier. So after we wash our hands, we're going to get our barrier first. Remember, we don't want to hold anything up against our uniform. So we don't want to get the barrier when we get the rest of the supplies. We're going to get the barrier first, put it on the table, and then go get the rest of the supplies and put them on the table. Good? So here, this is an important concept. Barrier first, barrier on the table, the rest of your supplies. Any questions on barrier rules? Like I said, really short, easy. Make sense? Okay, so now let's move on to privacy blanket. So dignity is essential. So is comfort, though. In here, in this room, how's the temperature in here? Pretty comfortable? Pretty good? Okay, to me, it feels warm. Why? Okay, different people interpret temperature in different ways, and I'm active. I'm up and moving around. Absolutely. So my perception of temperature is actually different than yours. Now let's think about a patient in a healthcare setting. That patient, sorry, Miss Jones, I'm going to expose you real quick. This patient is not dressed the same way I am. What is she wearing? A gown. Do you know how thin that gown is? It's pretty thin. And what is she covered with? A sheet. So thin gown covered with a sheet. Is she active? You think her perception of temperature and my perception of temperature is going to be the same? Anybody ever been in a healthcare setting? They keep it subarctic. It is cold. Now, I might be fine. I'm fully dressed. I'm running around like a chicken with my head cut off. And even though it's cold in here, I feel okay. Does my patient feel the same? All right, so they're already freezing. Now, take their sheet away. How do you think they feel? Very cold. Now, but there's another problem with this. This person is laying down. You're very vulnerable when you're laying down. Very vulnerable when you're laying down. She's also not dressed for company. She is in a thin gown and not much else. Laying down. She probably feels pretty vulnerable. Now, take her sheet away. She's probably going to feel like she's about to be somehow violated. If you walk into a patient's room and you just pull that sheet off, your patient's going to fight back. And you're going to be like, I don't know why. I just went in to give a bed bath or dress her or whatever, and she just started freaking out on me. Okay, let me put you in a gown, put you in that bed, cover you up with a sheet, and have some random stranger from the street. I'm just going to go out there and find any of them that I can find and bring that random stranger in here and let them undress you. How do you think that's going to go? Okay, so what we do matters, but the way we do it matters more. Does that make sense? This is vulnerable, guys. Pull that sheet off and it's really vulnerable. So we've got to think about things from the patient's point of view, not ours. So your mindset might be, I don't need to cover her. I've seen it all. Seen one, seen them all, don't really care. It's not about you. You might have seen them all. You think she wants you to see hers? Probably not. Okay. Make sense? So that's what privacy blankets are all about. It's about understanding that our patients are not dressed for comfort, that they may be cold when we take the sheet off, and their vulnerability is going to ramp up significantly. So if we understand all that, a privacy blanket starts to make sense. Because when we're going to take the sheet off of the patient, if we put a blanket on first and then pull the sheet down underneath, your patient remains covered, warm, but it also protects them from you. So yeah, that privacy curtain is going to help protect them from everybody out there seeing what they've got, but it doesn't protect them from the stranger that's in there with them. You. So the privacy blanket will do that. Make sense? Don't skimp on privacy blankets. Now, this is one of those things that you're going to hear out there. Oh, yeah. They're going to teach you about privacy blankets in school. We don't use that kind of stuff around here. In the real world, we don't use privacy blankets. Okay, I want you to put your grandma in that bed and let a total stranger come in and expose her. How do you feel about it? Don't skimp on these. This is a person. They deserve dignity. Does that make sense? Be careful with that one. All right. So I just went over this, but let's go through the slides real quick because I get talking and forget to push buttons. Your perception of temperature is different from theirs. Closing the curtain keeps the patient from being exposed. It protects privacy. It does promote dignity, but it doesn't protect them from you. So we're going to use a privacy blanket anytime the patient is uncovered or undressed. This is something you have to know. It's not going to be on the care plan. So let me stop right here because this is important. Everything up there on that back wall that we're learning is not going to be on the care plan. There's no care plan that's going to say use a barrier. There's no care plan that's going to tell you do the opening. There's no care plan that's going to tell you to use a privacy blanket. These are best nursing practices, and this is why you need this class. Because I can teach you to follow the care plan. That's easy. Those are words. You read them, you follow them. This stuff tells you how to follow them according to the standards that were set by the nursing profession. Does that make sense? So these principles tell you how. The care plan is not going to have this on it. So don't rely, you've got to learn this, not rely on the care plan. All right. So privacy blanket always ensures the patient is covered with something. So I'm going to turn this camera real quick over here. Okay. So when we have to use a privacy blanket, there's a couple of rules that go into using the privacy blanket. The first rule is don't snap it or shake it. When I'm changing my sheets at home, I usually do something like this. And you probably do too. Right? On this bed are dead skin cells, yeast, and bacteria that have fallen off this patient. When you do this, if I sprinkled powder on this bed, you'd be able to see it. But when you do this, it creates a vortex. And it brings whatever's on that bed right here where I can breathe it in. Now, what do we know about the holes on my face? They're wet. They're portals of entry. So if I bring all of those things right up here and I breathe them in, what did I just let into my holes? Pathogens. That is correct. Do you want to snap that blanket? No, when you do it at home, you're only breathing in your own funk. It's no big deal, but don't do that with a real patient. Good? The other issue is with snapping, you could accidentally hit the patient with that. Anybody ever been flicked with a towel? It hurts, right? We run the same risk here. So we unfold. We do not snap or shake. Okay? All right. At the end of the skill, when we're all done, so let me go back here. So we've unfolded the blanket, laid it out over the patient. We pull the sheet down. This makes sure the patient is always covered with something, so they're never exposed. So we pull the sheet down. We do whatever we need to do with the patient. Insert skill here. And then at the end of the skill, I've got to pull that sheet right up next to her face. That's where the sheet's going to go. What's on her face? Portals of entry, right? So if I take this blanket away and I pull that sheet up with gloves, remember, gloves are worn when we're around body fluids and skin openings. So if I touch that sheet with those soiled gloves and bring it up next to her face, what am I bringing up? Pathogens. So at the end of the skill, if you wore gloves, make sure you remove your gloves before you pull up the sheet. Good? So this is the very last thing we do at the end of the skill. To pull up a sheet, you're going to bring the sheet up over the blanket. Again, making sure the patient is always covered with something. So we'll pull the sheet up. And then we'll remove the blanket from underneath. Anytime we remove anything from the bed, we don't just pull it out and let all those trailing edges touch everything. When we pull it out, we always wind it up in a ball so we have control over it. Good? Questions? All right, remember that sheet's going to go right up next to their face. You don't want to import cooties. Now let's go on to linen rolls. Now we've already covered most of linen rolls. So you're going to hear me say the same things I just said. If a rule shows up on more than one principle, it means it's doubly important. Okay? So linen rules are going to be found in most skills. I have instructions on page 87. There's your notes. Linens cannot touch your uniform. Oh, we already know that one. But it's repeated, so that means it's important. You have to have clean hands to get your linens. Well, we've heard that one too. If it's repeated, it's important. So a lot of students ask, okay, well, how would I fail? What are some things I would do to fail? This is one of them. A lot of students will skip the whole opening, skip the hand washing, go straight over and grab their supplies to start the skill. It happens in this classroom every single class. Even though I have just spent 8 hours telling you not to do that, it still happens every single class. So remember, if it's repeated, it's important. Okay? So you have to have clean hands to get your linens. Don't snap or shake your linens. So washcloths, towels follows the same rules as the privacy blanket. Don't snap or shake. And the last thing that I want to tell you about linen rules is if you don't use it, you have to lose it. So don't take a whole stack of linens in the room and leave it there till later. Anything that's out of your sight is considered contaminated. You have no idea who sat on that stack of linens in the chair. You have no idea if somebody spilled coffee and picked up a washcloth and wiped it up and then put it back on the stack. You don't know what happened to those linens. You cannot consider them clean. So if you take what you think you need, anything you don't use, put it in dirty linen. Don't leave it in the room till later. You can't ever put it back on clean supply. So think of that as an ATM. You can withdraw. Can't shove stuff back in though. Good? All right. We'll cover the rest of linen rules in a future lesson. But for now, that'll get us started. So now that we have all of these rules that we've gone over, and if you look, we only have 4 left to learn. This is only class 2. And you're already over half done with your principles. Oh, cool. See, even balloons. All right, so now that we know these principles, let's focus on the steps required to pass the exam. Flashcards are available for you that go over the principles and the supplies and the steps. But let's talk, and I bring that up because you've got these in the flashcards. So let's talk about the other steps that aren't covered by the opening, the closing, the linen rules, privacy blanket, glove rules. So page 98 talks to you about dressing. I'm going to sum this up really quickly. Let your patient choose their own clothing. If they describe something that doesn't match, you can suggest an alternative, primarily because you're judged on the way they look. You know, if I've got CNAs that are dressing patients and I walk down the hallway and nobody matches and the buttons aren't matched up, and I got sloppy CNAs. I got CNAs don't care about my patient. That's going to reflect on you. So if your patient describes purple plaid pants and a yellow flowered shirt and you're like, oh, no, You can suggest an alternative like, hey, Mary, your white shirt would go really nice with those pants. Do you want to try that? Most of the time they go, oh, yeah, that's what I meant. But sometimes they'll argue and they'll say, no, I want my yellow flowered shirt. Okay, no problem. Maybe it's bingo day and that's her lucky shirt. Maybe both of her kids are coming to visit and one bought the shirt and one bought the pants. That happens probably more than you'd think. So even though they don't go together, you can suggest an alternative, but honor their wishes. Remember that everyone has the right to choose their own clothing. So when we're doing this skill, we're going to read our care plan. We're going to do our opening. Knock, knock, knock. Hi, Miss Jones. My name is Patty. I'm your CNA today. I'm here to get you dressed. Is that okay? Pull curtain, wash hands. Go get your barrier and put it on the table. Ask the patient, what do you want to wear today? They're going to describe an outfit. Get that outfit and put it on the table. If you're unsure, hold it out to them and say, is this what you chose? There will be 2 outfits on the rack, on the shelving. There will be 2 outfits. Make sure you are getting the outfit they described. You can verify it with the patient. And then put that on your barrier. You're going to need a privacy blanket because our patient is uncovered for this skill. So we're going to use a privacy blanket. Put that on your barrier. But you have to go get that barrier first. Now, you want to do all of this before you undress the patient. Can you imagine how vulnerable she would feel if we stripped her and she's laying there naked and then we say, oh, yeah, what do you want to wear? And then we leave. So get your clothing first. You want to minimize exposure when dressing the resident. So the way we do that is using a privacy curtain, privacy blanket, and getting the clothes before we undress the patient. Anytime we lift a patient, we lift from below with a flat palm, never from above. We're not the claw machine at Walmart. We don't do this. Always from below. Now, this patient is going to have a weak arm. We got to look at the care plan to figure out which arm is weak. And that's going to dictate how we actually dress them. And the way we remember this is USA first. USA first. Undress strong arm first. That just lets the strong arm do all the work because it's going to have to pull in to get out of the sleeve. And then the garment just slides right off that weak arm. No motion necessary. And then when we dress the resident, we're going to dress the weak arm first. So the sleeve just slides right on, no motion necessary. And the stronger arm does all the work to get into the sleeve and finish dressing. So USA first, undress strong arm first, dress weak arm first. Be careful when you're doing this. Don't cause injury. Your care is judged by the way your patients look, and don't leave anything on the bed, table, or floor. So everything that you use in the skill, you want to put away at the end of the skill. That's part of that clean environment. Call light will go in the stronger hand. So if we look at page 103 at the top, care plan tells us to dress the resident in a long sleeve, button or snap front shirt. Let's stop there for a second. It is like 100 degrees out there. It's hot. We all know it's hot. Care plan tells us to dress the resident in a long sleeve, but it's hot. Should we really dress that resident in long sleeves when it's hot? What do you guys think? Why? Easy answer. Follow the care plan. If you have concerns, who should know about those concerns? Because that falls under observations, right? But we use long sleeves for more than temperature. If the patient has a weeping rash, we're going to cover those holes with clothing. If the patient has an autoimmune disorder, they're usually photoreactive, which means exposure to sunlight will worsen their condition. So we cover their skin. Good? Makes sense? Okay. And I'm going to talk to you next week about why all old people are always cold, which can play into this as well. And then it tells us shirt, long sleeve, button or snap front shirt, pants, and socks. Does it say anything about undergarments? So do we put them on? Why? Easy answer. Care plan says no undergarments reflected here. Don't go above and beyond, guys. This is assuming your patient already has undergarments on. Okay. It tells us the resident's lying in bed, has a weak right arm. So it's going to indicate how we dress and undress. The resident is not able to help with dressing, and after dressing, leave the resident in bed. Those are our orders. Everybody good with that? All right. I've really quickly here got to show you this video. We're not going to get to range of motion. It's okay. Don't panic. We got lots of time built into the last half of the class. I'm going to bring that in probably on class 7. I got to take it out of here because I never get to range of motion. I always have to put it off. So we'll just move range of motion to class 7 and I'll work it in there. Okay. So don't panic. I'll get it. All right. So let me show you this video. I know we're really close on time. I will get you out of here. I promise.
Hello, Mrs. Jones. My name is Patty. I'm your CNA today. How are you? Good. I'm here to help you get dressed. Is that okay? Okay, I'm going to close your curtain. Let me go wash my hands, get my supplies, and I'll be right back. The first thing that I'll get is a barrier to put on my table to make sure that my supplies remain clean. Mrs. Jones, what would you like to wear today? Your light pink pants and dark pink shirt? Okay. Is this the outfit that you described? Wonderful. I'll get a privacy blanket as well. Okay, Mrs. Jones, I'm going to spread this privacy blanket out over you. This will keep you warm and help protect your privacy as we do this skill. I'm going to carefully unfold the blanket, being careful not to snap or shake it as I lay it out over you. Once the blanket's in place, I'll pull your sheet down to the end of the bed. Okay, Mrs. Jones, I'm going to place your socks on now. We'll take one of the socks, scrunch it all the way up to the toe seam, put it over the foot, making sure the toe seam is lined up. That's important. Lift from below and support at the ankle, and smooth the sock over the heel. Now we'll go to the other side. We'll scrunch this sock up, put it over the foot, making sure the toe seam is lined up. Lift from below and support at the ankle, and smooth the sock over the heel, minimizing wrinkles. Now we'll help you put your pants on. We're going to make sure the tag is in the back. I'm going to insert one of my arms into the legs of the pants and scrunch it up so I have control over all the material. We'll then place it over your foot, lift from below, and smooth it over your heel. We're going to repeat on this side. I'm going to put my hand inside to scrunch up the leg of the pants, and then place it over your foot, lifting from below and supporting at the heel while we finish putting on your pants. Okay, Mrs. Jones. Now I'm going to lift your pants up over your hips. If I can have you raise up your hips as high as you can on the count of 3. 1, 2, 3. I'll make sure that your pants are over your hips and then cover you back up. Okay, Mrs. Jones, I'm going to elevate the head of the bed now. Please tell me when you're comfortable. And if I can assist you to lean forward, I'll untie your gown. Notice I'm using the
Thank
upper
you.
back, not the back of her head.
I'm going to tuck a corner of the blanket behind your back as you sit back. And now I'll remove the gown from this side. We're going to undress the strong arm first. Since our care plan indicated your right arm is weak, we'll undress your left arm first. I'm going to the other side of the bed now. Okay, Mrs. Jones, I'm going to undress this arm. Being careful to minimize the movement and support the arm at the elbow as I lift it off the bed. We'll remove the soiled gown.
You
Go
notice
ahead
how
and
the
rest your
blanket
arm
is
back on the bed. Okay, now I'm going to assist you with your shirt. I'm going to scrunch up the arm of the sleeve and put my hand through backwards, keeping your arm supported on the bed. I'm going to lift your hand and hold it as if we're shaking hands. This will keep all your fingers together as we place the sleeve over my hand and then over yours. Once we have the sleeve in place on your arm, we'll extend your arm out. I'll support at the elbow as I bring the sleeve the rest of the way along your arm.
Pay attention.
If I can have you sit forward, Miss Jones, let me assist you. Thank you. Make sure that you remain covered. And smooth the shirt along your back.
Am I talking to the evaluator?
Come on back, Mrs. Jones. Thank you. Okay, Mrs. Jones, I'm going to assist you in putting your other arm in your sleeve. So I'll scrunch it up, put my hand in through backwards. And Miss Jones, if I could have you reach your arm up and back for me. I'll assist you to put your arm in the sleeve. Okay, Miss Jones, we'll rest your arm back on the bed now while I straighten your shirt and make sure that it is snapped appropriately.
Make sure everything lines
Adjust
up.
your clothing to make sure it's neat. Can I have you lean forward for me, please? Thank you. And I'll make sure that this blanket can be removed. Okay, Ms. Jones, I'm just going to gather up your privacy blanket and place it in soiled linen along with your gown. I'll be right back. Okay, Mrs. Jones, I'm just going to adjust your clothing for neatness and appearance and make sure that it's fastened appropriately and that you look good. Very nice. Okay, you have your call light here if you should need anything. Can I get a magazine for you? Okay, I'm just going to throw your barrier away and open your privacy curtain. Now we'll go wash my hands. After washing my hands, I'll think about the steps of my skill, make any corrections, and then tell the evaluator my skill is done.
The call light needs to be in her hand. All right, any questions? Any questions on what we went over today? I know I talked nonstop. Remember, you have 2 chapters of homework tonight, chapters 2 and 3. And CPR is on Saturday at 9 a.m. You don't have to pre-register, just show up.
Okay.
If you want to take CPR on Saturday. I'll have one more class for CPR on week 4 Monday. If you still need CPR at the end of class, that's fine. Otherwise, find some time to do something fun this weekend. It's not all about school. And I will see you guys on Monday. Have a fantastic day.
Thank you.